Oh. Hello, sir.
Hello. Am I audible?
Yes.
So, good afternoon, good evening, all the dignitaries. In today's session organized by Patna Obstetrics and Gynecology Society along with other society. And it's my honor to introduce today's MOC, Dr. Shruti Jaswal, madam. Society, please change this one. Yes. It's my honor to introduce madam, although madam doesn't need any kind of introduction, but it's my formality, it's my responsibility to introduce in place. So madam is the Secretary, Patna Obstetrics and Gynecology Society, and specialist chief consultant at Home Hospital, Patna, and madam is the East Zone Coordinator, Adolescent Health Committee POCSO. So with this short introduction, I request madam to take over the session for further proceedings. So thank you very much, and over to you, madam.
Okay, so a very good evening to everyone present here, respected all the dignitaries. I bring warm greetings from Team Patna OBGY Society to all of you. And today we have gathered here for a mixed bag program, so where we have 4 different topics to be discussed by the great orators today who are present here. I greet my chief guest of today, Dr. P.K. Shah sir, Dr. Rishikesh Pai sir, and the guest of honors, Dr. Pardesi sir, Rajinder Singh Pardesi sir, Dr. Ajay Mane sir, Dr. Sarita Bhalerao, and Dr. Suvarna Khadilkar. So let us begin with prayer today. So may I request the shield people kindly show the lighting and we inaugurate the program.
Sorry, the volume is not coming up.
Is it audible, ma'am?
Yes, it is audible, but the lighting the lamp couldn't play. So it was not audible.
Saiti, please share the screen once.
Alternate plus जी करतो.
So thank you. Sometimes this error happens. So we begin the program with this. I first of all would like to convey to you my deep apologies that Dr. Vinita Singh, she is busy in some major OT, so she couldn't come. President of Patna OBGY Society, on behalf of her, I'll be giving you the welcome address. I welcome first of all our chief guest, Dr. P.K. Shah sir, Dr. H.D. Pai sir. Sir, we are very happy to have you here. Thank you, sir, for coming. Sir had some technical problem. P.K. Shah, sir, thank you so much for accepting to be the chief guest of today's mixed bag webinar. And I also welcome our guest of honors, Dr. Rajendra Singh Pardesi, sir, Dr. Ajay Mane, sir, Dr. Sarita Bhalerao, ma'am, and Dr. Suvarna Khadilkar, ma'am. Even Dr. Suvarna has placed a message, she might join in between. So, and I welcome all the esteemed speakers and all the respected chairpersons of today. So I would just like to name a few: Dr. Nandini, Dr. Anjali, Dr. Swati, Dr. Suvarna. So all of you, I welcome you from core of my heart. So now to start with, may I have Dr. P.K. Shah sir to kindly have the CV of Dr. P.K. Shah?
Yes, ma'am.
Yes. I'm really blessed and honored to have you, sir, in this webinar as the chief guest. Sir is a professor and unit head Department of OBGY, State GS Medical College and KEM Hospital, Parel, Mumbai. Then past Dean, Indian College of Medical Ultrasound, past President, Indian Association of, that is IAGE, then FOCSI, past President of IFUMB, past President of Mumbai OBGY Society, past President of Associations of AFTT, then Senior Medical Teachers Association, Sion Hospital,
Yeah,
past Vice Dean. Sir has many accolades to his credit, sir. No, but we just take you as an idol, sir. What more we can say about you, a towering personality like you? Just maybe have some words of blessings from you, sir.
Thank you, Supriya, very much. And thank you for inviting me to this webinar and making me a part of it. The Mixed Bag webinar organized by Patna OBGYN Society. What is surprising is that there are so many societies from Maharashtra, like Aurangabad, Satara, Meerut, Nanded, Ahmednagar, Solapur, Baramati, Hingoli, Osmanabad. They are all joined. It's so nice to see the office bearers of all these societies, either chairpersons or speaker, etc. It's nice to share a platform with Rishikesh Pai. I think we're doing it for the first time, Rishi, as chief guests. And there are 4 guests of honor. Dr. Ajay Mane, Dr. Rajendra Pardesi, Dr. I think Suvarna and Dr. Sarita.
Yes.
What is important is that Patna OBGYN Society President, Dr. Supriya Jaiswal, she's the secretary, and the president, Dr. Vinita Singh, have organized this. And they got all the Maharashtrian societies literally to participate. Yes. And one Dr. Niba Mohan has, I think, done the job to gather all these people and have scientific program. What practical aspects of this I have liked is that, though it is called mixed bag, they're all very important topics that have been selected, like medical legal issues in day-to-day practice, then HTP, preeclampsia, indemnity insurance, which nobody talks about in any of the webinars, Rajendra, and surgical treatment of PPH. So nice to have Dr. Sudesh Doshi, Dr. Gorak Mandrupkar, Dr. Rahul Vani, and Dr. Fasiha speaking on all these 4 topics. So it's so nice to gather in the evening for all these important topics from the practice point of view. Thank you very much, and I wish you all the very best for whatever you do, Supriya, and for your election. Wish you all the very best. Thank you so much for having me.
Thank you, sir. Thank you. Thank you, sir. And thank you for your pearls of wisdom, sir. Thank you very much. So moving forward, can I have the CV of Sir H.D. Pai, sir? So, sir, Dr. H.D. Pai, sir, thank you for accepting to be the chief guest today a very short notice. Sir is the founder and medical director of Bloom IVF Group, President-elect Foxy, Administrator Foxy, Manyata Initiative, Director of Corporate Affairs, International Federation of Fertility Societies, Adjunct Assistant Professor at Eastern Virginia Medical School, USA, postgraduate teacher in gynecology at DNB Examinations, India. Then he has got special interest in infertility, endoscopy, IVF, XC, egg freezing, and genetics. Sir has got many major achievements, awarded with esteemed fellowship and NU of the RCOG Royal College of Obstetricians and Gynecologists, London, UK, past Secretary General, Senior Vice President, Deputy Secretary General, Treasurer, Chairman Foxy, past President SR, IAG, MOX, and MSR. He's been honored with so many awards and publications. Sir is a celebrity doctor who has had more than 20 plus Bollywood celebrities have children and freeze their eggs. Sir, congratulations for that. Awarded with 50 plus awards, including prestigious Lifetime Achievement Award by ISSRF 2019 and SR 2020. Then delivered many orations and invited as faculty across the world. editor at over 16 plus books and written more than 50 chapters, founder editor of Journal of Gynecologic Endoscopic Surgery, then editor Indian edition of British Journal of OBGYN BJOG, founder chair Indian SIG American Society of Reproductive Medicine ASRM, numerous research publications to his credit, and moreover, sir is a very friendly, very nice gentleman. Sir, over to you for your words of wisdom, sir. Thank you, sir, for coming here. Sir. Hi, sir.
I think his network is gone.
I think so.
No?
Hey, Rishikesh sir was there, no? Yeah, he's there. Sir.
He's mute.
Yes, sir.
He's mute.
Sir, you are mute.
Sir,
Sir, you are mute.
Sir.
Unmute karta hu.
Yeah.
Can you hear me?
Yes, sir.
Hello. So sorry. I'm thankful, Supriya, for inviting me. You and Dr. Vinita have been my very good friends and wish you the very best of life. I'm very privileged to be sharing the dais with Dr. Pikesha, who is the father of ultrasound, I would say, along with my boss, Dr. M.Y. Rawal. He both were we used to look up to them, and he is a great man. He has popularized ultrasound all over, and I have so many of my friends. Rajendra Singh Padesi will now become the president of AMOX, very, very good person, good human being. Ajay, his friend, who will become the vice president now. Congratulations, Ajay. And Sarita and Suvarna, who are, the future of Foxy. And so many of you are there in the audience, all my friends, so many societies are there. So I think today's program is well arranged by you, and without delaying much, I would like to wish you the very best, and we are looking forward to an excellent academic deliberation. Thank you for inviting me for this. Thank you.
Thank you, sir. Thank you very much, sir, for coming and for your words of wisdom. Thank you, sir.
Thanks.
Now, our guest of honors, the very respected guest of honors, may I have the CV of Rajendra Singh Pradesi, sir? Sir is the first vice president.
It's okay, Supriya.
Sir is a wonderful person. That much I can tell you, sir. He is
I wish to add only one thing. See, Dr. in my biodata, I am student of Dr. Pikesha. I think this biodata is sufficient. So, respected Dr. Pikesha, sir, Dr. Rishikesh, Dr. Sarita, Dr. Suvarna, Dr. Ajay, and Dr. Sudesh Doshi, and all faculties and chairperson of this webinar. I think this will be a really wonderful webinar with interested topics. As Dr. Pikesha told, it covered all variety of topics. I congratulate Dr. Supriya Jaiswal and wish her every success in her future endeavor in Foxy as chairperson of Adolescent Health Committee. I don't want to be in between you and all scientific. I wish every success to this webinar. Thank you. Thank you so much for inviting me. Thank you. Thank you so much.
Thank you, sir. Thank you for your good wishes and for coming here and being the guest of honor. Thank you very much, sir. Thank you. Now over to next, Dr. Ajay Mane, sir. Thank you for being the guest of honor of today, sir, and accepting our invitation. So, sir is the National Inspection and Monitoring Committee member of
Supriya ma'am.
Yes, sir.
Yeah, we can skip that.
But then, sir, you are the vice president elect, sir. That I can tell.
That is all your and my seniors and Gurujans' blessings that I have become that. But we can skip the biodata.
Okay, sir. So, heartiest congratulations for that, sir. And may I have some words from you? Yes, sir.
Thank you, madam. As Pardesh sir said, when Pikesha sir is there, he is the Gurudev of all Gurudev. So, not in front of him. So, thank you. And Sarita madam is also is there. She is amongst great personalities from Foxy, a great daughter of a great mother. That I can say. So you have involved all the societies. Those are Aurangabad, Satara, Miraj, Nanded, Ahmednagar, Solapur, Baramati, Hingoli, Usmanabad, and Yavatmal. the newly, and your chief guests are the great personalities PK Shah sir, Rishikesh Pai sir, and all guest of honors Rajendra Singh sir, who is my mentor, Sarita ma'am, who has blessed me, and Suvarna madam, both from Mumbai and Foxy, and all the speakers, Sudesh bhai, Dr. Gorak sir, Dr. Rahul Wani sir, and Dr. Fasiha, the great personalities, all the chairpersons. So it is very nice program because the topic are medical legal issues in day-to-day practice. Then second is HDP and preeclampsia, indemnity insurance and doctor, and PPS surgical treatment. All are practical topics basically. So those are very much useful to all the delegates from Foxy and all of them. Rather, it is useful to IMA also because these three topics are useful to them also. So thank you very much, Supriya ma'am, for inviting me here on this platform and uh, inviting all the great speakers and having one webinar. So best luck for your life and best luck for your election also. So thank you very much, ma'am.
Thank you, sir. Thank you. Thank you again for your best wishes and for coming here and your words of wisdom, sir. Thank you. Now, may I invite Dr. Sarita Bhalirao, madam? She's
Dr. Supriya, you don't have to introduce me. Don't worry. Yeah.
immediate past, present, and very wonderful person you are.
Thank you so much, dear Dr. PK Shah, Dr. Rishikesh Paisa, Dr. Pardesi, Dr. Mane, Dr. Supriya Jaiswal, and all my seniors. It's really, I thank you all for inviting me here, and it's a wonderful idea to have a joint program here with so many societies, and that is really the beauty of the webinars, that we are able to connect, and it's really a pleasure to see everybody. You have chosen very nice topics, as Dr. Ajay Mane said, and I think that it's very important to include things like professional indemnity in our webinars, because really we need to know, and so many times people ask questions, how much should I have, should I have one, should I have two things. So I think you have really charted a very nice program, and it's going to be very, very helpful to everybody. And I think you're a really very lovely and a dynamic person, and I wish you all the very best for the oncoming election. Thank you very much, Dr. Jaiswal.
Thank you, ma'am. Thank you. Thank you for your lovely words. I'm elevated. I'm very happy. Thank you for you have come. So, and now we move over, like actually we have finished with the inaugural part, and because Madam Suvarna will be joining late in between, she is somewhere engaged. So we move over to the scientific program, and to begin with, we start with our chairpersons. So can I have the CV of the chairpersons? First session, medical legal issues in day-to-day practice. So this, yeah. So the speaker is none other than Dr. Sudesh Doshi. Sir, he is the chairperson Medical Legal Committee, Foxy. Now, we start with the chairpersons. We have Dr. Medha, working as consultant at Srinagar Hospital, Krishinagar Sagar Hospital, Koregaon, in rural area for 30 years. Ma'am, you have lots of experience that. Currently working as Secretary, Sarkar OBGY Society, Secretary IMA, then special interest is adolescent health and family welfare. Welcome, madam. So the next chairperson is Dr. Anuradha Chevalier. She is FICMCH diploma in assisted reproduction, University of Kiel from Kiel, Germany. Diploma in pelvic endoscopy, Director Chevalier Hospital and Ajanta Fertility Center, Aurangabad. Practicing IVF endoscopy for last 20 years. She is also the founder member of MSR President, Aurangabad OBGY Society and Foxy Recognized Training Center for ART and infertility. Madam, I welcome you. Now, we have Dr. Kishore Atnukar. He is the president of Funded OBGY Society. Sir, I welcome you. Now, may I request the first chairperson, Dr. Medha, to kindly start introducing the speaker, Dr. Sudesh. Dr. Medha, ma'am, she was there, no?
She has not joined it.
Oh, so what I do is I introduce the speaker. So, sir is a senior obstetrician working since 25 years in rural setup at Pandharpur, experience of delivering over 12,000 babies at his nursing home, and then chairperson Medico Legal Committee AMOX, member NIMC FOCSI, past president of this Pandharpur OBGY Society. Sir, over to you for your deliberation. We are eager to hear you.
Thank you. I want to share my screen.
Yes, you can, sir.
How do I?
So please click on share screen symbol.
Yeah. I clicked on share screen.
And then one pop-up will be raised and you can share the screens.
But my screensaver is not coming here. Or may I open the PowerPoint presentation first and then share the screen?
Yes, sir.
So this, sir, the green button on lowermost part.
आधी ओपन करा आणि नंतर स्क्रीन शेअर करा.
तसं करा.
हा तसं करा. ओपन करा, फुल ओपन करा ते.
येस.
आता स्क्रीन शेअरवर जा आणि डेस्कटॉपलाच ठेवा तुमचं प्रेझेंटेशन.
हो, डेस्कटॉपलाच ठेवलंय.
म्हणजे इझी होतं ते. फाईल काढायला इझी होतात. आता शेअर करा.
झूम काही
नाही येईल ना. शेअर करा ना, शेअर.
हा, एक मिनिट. झूमचं हेच ओपन होईल ना.
नाही शेअर तर होतं ना.
शेअर. येस येस, आय विल शेअर. जस्ट मिनिट. हा शेअर स्क्रीन.
चार्टच्या नंतर शेअर स्क्रीन बघा. चार्ट आणि रेकॉर्डच्या मध्ये शेअर स्क्रीन.
येस येस येस. हा येस.
एक्झॅक्टली येतंय. हा झालं.
तुम्ही नेहमीच आमच्या बोटाला धरून आम्हाला सगळं शिकवलं. थँक्यू सर वन्स मोर.
So can you make it full screen, sir?
Yeah. Thank you everyone for that opportunity. Patna OBGY Society and all of the organizers for inviting me to speak this thing. Thank you, Dr. Ajay Mane, Dr. Pardesh sir, and I pay all my tributes to our all teachers like Dr. Ruchikesh Pai sir, PK Shah sir, and all the dignitaries. I will be speaking on medical legal aspects of OBGY practice. Dr. Ajay Mane had spoken some different aspects. Now I will be speaking on some two different aspects. I'll be basically speaking on three aspects. One is I'll get a quick sweep through the important judgments which are affecting us. Then I'll be going around the MTP amendments which are happened in 21, and then I'll be speaking something on POCSO. Now, important judgments which are affected all of us are a few things. One was VP Shanta against IMA. This judgment got all of us into the ambit of CPA, that is Consumer Protection Act in 1995. So we are now service providers and patients are consumers, and we have to act accordingly. This defined the relationship between the patients and the doctors. Then one more judgment was Pandit Parmanand Katara versus Union of India. Now these are two aspects, one aspect for the patient side and one aspect for the doctor side. The patient side, that the Constitution of India, Article 21, there is an obligation on the state to preserve life. So every doctor has a professional obligation to extend services to protect life. So whenever there is a dire emergency, nothing taken into consideration, no money, nothing. You have to save the life of the patient or give basic treatment to the patient and seek as many help as possible to the patient. But at the same time, law courts will not summon the doctors unless evidence is necessary, and doctors' time will not be wasted in the court of law giving evidences. So it was on both sides. The next much important thing was Jacob Matthews versus State of Punjab. Here the Supreme Court has given the guidelines, and now also the government of India has also given guidelines that doctors should not be arrested in the routine manner. There's a lot of things, paragraph, we all know this, so I will not be reading all these things. But now the Supreme Court guidelines are not enough. We have to be proactive. We saw what happened in Rajasthan. We had a similar case last week only in Ahmednagar. But Ahmednagar people, along with all POCSO officials, got together, they spoke to the police, they made them aware that the doctors will not be arrested, and also under the Hospital Protection Act, the culprits were arrested. Two of the culprits have been arrested. Dr. Ajay Mane, Dr. Rajendra Singh Pardesi were instrumental in activating the things, and Dr. Bansi Shinde from Aurangabad, and all of them got together, and the culprits are under the purview of law. So there is a good thing. So we have to know that only laws will not help us. We have to fight. We have to pressurize the police. We have to pressurize the politicians so that the implementation of law is done and all the law amendments are practically imposed. So that is what is necessary. The police are also made aware of this. Time and again, circulars have come from the central government, from the police officer, from the health ministry, that police should know. And one thing which I would suggest, and which all societies are also doing, that please get into connect with local police, the police officers, the police commissioners, have a chat with them, have a tea with them, and please make them aware of this law, that doctors should not be arrested in the routine manner unless until the medical board gives its opinion. Then there was one more case which was an important judgment, which was Samira Foley versus Dr. Prabham and Janda. This was about consent. Many times we take it granted that consent has been given, but no, it is not. It has to be implied consent. It not only implied, but it has to be a informed consent. We have to inform the patient what all things are to be done. We have talked in length about consent. We have FOCSO people, we have all of the people helping you out. We have Dr. Mane sir, me, then Dr. Patel sir. We all are always talking about consent. We have on our FOCSO website consent format, standardized consent formats for almost 25 procedures. We all can go through it, and we have to have informed consent about all practical procedures. In this case, we know that the patient's hysterectomy was done and patient's ovaries were removed when the consent was not taken for removal of ovaries. And so the doctor was tried and punished. So please see to it that the consent is properly taken. So consent, we know it is implied, expressed, and informed consent. What is implied consent? Patient comes to you, sits on the table, and you examine her. So it is implied that patient has consented for you. Express consent, you tell the patient, I'm examining you, that is express consent. And informed consent, you tell patient everything about the procedure, take a signature, and that becomes informed consent. One more point about consent is not unilateral. Consent is a contract in between two parties. So whenever a written consent is taken, it is always important, which part may be missed by us, is that not only the relatives or the patient signs the consent form, but the doctor who is operating or who is anesthetizing the patient or the in-charge doctor has to sign the consent on behalf of the doctor. So on the consent form, doctor signature is also equally important. Now we're coming to the particular situations. Now we say, when we are doing a tubectomy or a sterilization procedure, permanent sterilization procedure, is the consent of spouse necessary? Now there are conflicting views, but to be on the safer side, I would say, and we always suggest that please take the consent of the spouse, because afterwards, if there are any legal hassles, then the spouse may sue you, because this is a permanent procedure. So please take the consent of the spouse also. Now this is not the thing with MTP. MTP has a separate law for it, whereas sterilization will not have a separate law for it. Sterilization we go with this regular rules, but MTP has a separate law for it. And MTP law, it doesn't mention anywhere that the spouse or the partner or the biological father has to sign the consent form. Only the person who is undergoing MTP, if she is more than 18 years and of sound mind, then she can sign the MTP consent. No one else is necessary. If she is less than 18, or if she is not mentally sound, then her caretaker has to sign the form. Her guardian has to sign the form, and not them. In all other conditions, whether she's married or not married, whether she's living with her husband, she's living with her spouse or not, she's living with her in-laws, or she's living at her mother's place, any person who is more than 18 and of sound mind, she can undergo MTP with the consent of herself. No other consent would be necessary. Now, one more thing, we are in habit of small hospitals, nursing homes, that we write that I'm ready to get operated by any doctor under any anesthesia to any extent, and any operation can be done. No, this sort of blanket consent will not be valid anymore. Consent, we have to have specific consents. You have to explain the patient the procedure, the anesthesia, the probable outcomes of it, the failure rates, what are likely complications, how they will be handled. All these things are to be explained to the patient and express consent is to be taken. And in case of life-saving conditions, then consent is not required. This is a rule. One thing about blood transfusion. Now, Supreme Court in one case has specifically mentioned that blood transfusion is a separate procedure, and unless and until it is a life-saving procedure and the patient is not dying or something like that, it is very direly necessary to give blood without taking the consent. You have to take separate consent for blood transfusion. Blood transfusion consent is also available on POCSO form. So blood transfusion is a separate procedure and a separate consent should be taken for it. Every time you transfuse separate blood, you take a different consent. Now, consent for minors, for patients who are less than 18 years, then the consent of the guardians and legal guardians should be taken. Now we come to another point. I know I'm skipping some points or I'm going very fast, but we have to cover a lot of points in smaller time. We'll come to amendments in the MTP Act, which have come recently. And I would stress on the points which are different from previous ones. Now, as know broadly, we know that the limit has been extended from 20 to 24. Beyond 24 also we can do it. But the points which will matter to us will be emphasizing on them. Now, who will conduct the MTP? Now, there were two things. Sorry. In old law, while doing MTP, the person who was qualified to undertake MTP was, there were A, B, C, D, three things. Now in C, it was written that a person who has assisted a registered medical practitioner in performance of 25 cases of medical termination of pregnancy, with at least 5 being performed independently in a hospital established or maintained training institute government. Now this training would enable the person to do only first trimester MTP, that is up to 12 weeks, and for terminations up to 20 weeks, the experience of training as prescribed under A, B, and D shall apply. Now A is what? A is person who is registered before the MTP Act. I don't think anyone of that age is now practicing obstetrics, so that is gone. Then B is gynecologist, that is who are postgraduate person. So now what has happened in new CA, category CA has been introduced. Now what is this CA? This is very important. A registered medical practitioner shall have the following experience and training for conducting termination of pregnancy up to 9 weeks of gestational period by medical methods of abortion. So a new category of people who were not qualified previously to do medical methods of abortion have now become eligible. And what is their eligibility? First is they are MBBS, that is a registered medical practitioner, and their name has been registered in the state medicine, and they have experience at any hospital for a period of not less than 3 months in practice of obstetrics and gynecology, or has independently performed 10 cases of pregnancy termination by medical methods of abortion under the supervision of a registered medical practitioner in a hospital established or maintained or training institute. So this training institute would be government institute. But what is CA1? Experience at any hospital for not less than 3 months in the practice of obstetrics and gynecology. That means a person who is done MBBS and has had a residency of 3 months in any obstetrics and gynecology hospital, who has an MTP center and who has prescribed medical pills, this person now would be eligible to give medical abortion. So this is a new thing. Previously, these people were not allowed, but now an MBBS person only with 3 months of experience in any practice of obstetrics and gynecology will be eligible to give MT pills. So this is a very important thing. A new class of people have been included to make abortion more inclusive so that they can give medical abortion pills. Now, section 5 has been amended. Now, this section 5 was about punishment for not keeping the privacy of the patient or secrecy of the matter. So now, the section 5 has been amended, and what has been said that no registered medical practitioner shall reveal the name or other particulars of woman whose pregnancy has been terminated under this act, except to a person authorized by any law for time being in force. Now, this is okay. This is what has been the same, but what has been changed is the punishment. Previously, it was only a fine of 1,000 rupees, and now if we contravene the privacy of the patient, then we shall be punishable with imprisonment, which may extend to 1 year, or with fine, or with both. So now this is very important because many times it is very difficult to keep secrecy of this patient. In many times about keeping insurance bills, and they want bills and all, it becomes very difficult. So be aware, you should not mention the name of the patient anywhere. Now, few forms have been changed. Previously, Form 1 was there, which was RMP opinion form, was the same form from pregnancy up to 20 weeks. Now this form has been changed, and what has been changed is previously we required signature of 2 medical practitioners from 12 to 24, 12 to 20. But now we do not require signature of 2 practitioners. So the name of 1 practitioner has been removed, and it is only signature of the registered medical practitioner. So Form 1 remains little changes, that is up to 20 weeks, only 1 signature will be required, and only 1 person's opinion is necessary to sign the form. Now the indications A, B, C, D, E are same as they were priorly. There is no change. So the Form 1 remains same till 20 weeks. Till 12 weeks it is the same. 12 to 20 weeks you don't require to have 2 signatures. Only 1 signature will be enough. Now Form 2. Form 2 is the monthly summary which we give to our sub-district hospitals or civil surgeons or district health officers every monthly. Now this monthly form is little changed, because previously we used to have only 2 categories, less than 12 weeks and 12 to 20 weeks. Now the summary will have subheads, including the point number 3, where it is up to 9 weeks, then up to 12 weeks, between 12 to 20 weeks, between 20 to 24 weeks, and beyond 24. So these additional columns have been added, and while monthly reporting you have to write in all these columns. Now one more thing which has happened is, up to 20 weeks the indications remain the same. They have not changed. Priorly whatever the indications were there, they are the same. But now from 20 to 24 weeks the indications have changed. They are a little different, and I will be going through them shortly. So those indications you have to tick. So this is the change in Form 2. Now one more thing is, who will form the opinion? Previously we always used to have debate that a person who has undergone government training is eligible only to do MTP up to 12 weeks, then whether his opinion would be valid beyond 12 weeks and up to 20 weeks. It was a controversy, but now the law has made it quite clear that for the purpose of subsection 2A of section 3 of that, the opinion of registered medical practitioner, which is required for termination of pregnancy at different gestation layers, should be following, namely till 9 weeks of gestation, whatever is the eligibility of a person to undertake a MTP, that is clause A, B, C, C, A, and D. That means anyone who is eligible to terminate pregnancy up to 20 weeks can form opinion for 9 weeks. Now, till 12 weeks of gestation by surgical methods, the new category which has been added, CA, that is person with only 3 months training, he is not eligible to form an opinion. So now person is to form an opinion, whatever qualifications are there to undertake MTP, same are the qualifications to form an opinion. So beyond till 12 weeks, A, B, C, and D will be qualified, and beyond 12 weeks, only A, B, and D will be allowed to take the opinion. So now the law is clear about who will form an opinion, whether this termination is to be done or not. The same qualification which is required to terminate a pregnancy is the same qualification to form an opinion. Now these are the new indications, or the new set of indications, including previous ones, for 20 to 24 weeks. The most important thing which we need to understand is that the indication of failure of contraception is not available beyond 20 weeks. Now that is a very important point, because we always think that failure of contraception is a valid indication. Yes, it is a valid indication, but beyond 20 weeks, failure of contraception cannot be used as an indication for termination of pregnancy. So what are the indications which can be used beyond 20 weeks? One is survivors of sexual assault or rape or incest, very fair. Then minors, if she's less than 18 years, obviously it becomes under POCSO, so she has to have very right, or she will desire to terminate the pregnancy. The change of marital status during the ongoing pregnancy, this is very important, because this is going to affect the mental health of the patient, either a widowed or a divorcee, whatever it is. Women with physical disabilities, and yes, disabilities have been defined as major disability as per the criteria laid down under Rights of Person with Disability Act. Mentally ill women, including mental retardation, And the fetal malformation, yeah, this is very important. This was the indication available till 20 weeks. It is also available beyond 20 to 24 weeks. And women in pregnancy in humanitarian settings or a disaster or emergency situations as may be declared by the government. And this has been very wisely put in there. Few of our POCSians insisted on doing this because suppose there is a war, suppose it was corona and people didn't have access to MTP centers and the pregnancy goes beyond 20. Yes, then these are the humanitarian settings or disaster or emergency situations declared by government where pregnancy may be terminated beyond 20 weeks up to 24 weeks. So rules or indications for 20 to 24 weeks as we have gone through this. Now this is the form E, which is required beyond 20 weeks. Till 20 weeks we fill form 1. Now beyond 20 weeks till 24 weeks form E is to be filled because form E will be had a sign of 2 registered medical practitioners and the indications will be different. Now beyond 24 weeks it comes to the medical board in the medical college or the district hospital. The medical board has to be formed. They will examine the patient and her reports which may approach the medical termination under the subsection 2B of 3, and they have to form a opinion in form D, and they have to ensure that the termination procedure when advised by medical board is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of a request for medical termination of pregnancy under subsection 2 of the section. So they have to form an opinion within 3 days and the termination has to be taken within 5 days. These are the various powers and functions of the medical board that they will be allowed to, they will form an opinion in form D whether to allow or deny the termination of pregnancy beyond 24 weeks under the subsection, and they will co-opt other specialists in the board and may ask for any additional investigation if required for the pregnancy. Now this is form D which is available on the internet. You can go through it. Now I will have, do I have some more time, madam?
Yes.
Hello?
Yes, sir. Yes.
So I will have a few more slides, 2 or 3 slides about, I have covered MTP, I have covered consent, I have covered important judgments. Now we will go salient features of POCSO. Now we all are being afraid of this POCSO Act, which is Prevention of Child Sexual Children Against Sexual Offences Act. That is a very important act, very finely drafted, but there are a few things which are worrisome and which are very worrisome to us. So it defines what are various sexual offenses like sexual offense, penetrative, non-penetrative, aggravated sexual offense, so and so forth, and various fines and various punishments have been defined under that. So that part apart, what is more important for us is section 19, section 20 and section 21. Now section 19 says that any person who knows that such an act is being done or any person who has an apprehension that such a crime has been committed, then the reporting of every sexual assault if the patient is less than 18 years at the time of alleged or actual intercourse has to be done compulsorily. So what is the outcome out of this? That if you see any patient who has not completed 18 years and find that she is pregnant, or you find any injuries over the sexual organs or anywhere on the body which are likely to be committed as a sexual crime, then it is bound, you are duty bound to report it to the police. It doesn't matter whether the patient is pregnant or not pregnant. If she is less than 18, then you are duty bound to report it to the police. Why you are duty bound? Because what it says, notwithstanding anything contained in the Code of Criminal Procedure, any person, including the child, who has apprehension that an offense under this act is likely to be committed or has knowledge that such an offense have been committed, he should provide such information to the Special Juvenile Police Unit or the local police. Though we do not have any liability, whether civil or criminal, for giving such information for the purpose of section 1, but if we fail to inform the police or the Special Juvenile Unit, then any person who fails to report the commission of an offense under the subsection 1 of section 19 or section 20, or who fails to record such offense, that is for the police, under subsection 2 of section 19, shall be punished with imprisonment of either description, which may extend to 6 months, or with fine, or with both. Now, this is very important for us because police is likely to trap us in this point. Though we know may not be arrested for medical negligence, but this is a totally different law. So if we fail to inform the police that such and such cases happened, then we are liable for a fine or imprisonment up to 6 months. So this is very important. So this is my take-home message, that please inform your local police about any patient who comes in the OPD, whether married or unmarried. You have to inform the police. If the police is not ready to take the information, it is binding on them also. They will also undergo punishment. Please give it on phone or WhatsApp message, or the most easiest thing is give it on an email, so that you know you have proof that you have informed the police, and the police may act with it or may not act with it. So this is about POCSO. Now, one last slide. Many a time we make mistakes because we very rarely give death certificate. As obstetrician gynecologist, God forbid me, but we have very rare instances of giving a death certificate. People in medicine, people in surgery, people in orthopedics, people working in trauma, they are in the habit of giving death certificate, but we very rarely have to fill a death certificate. So while issuing a death certificate, what important precaution we have to take? If the cause of death is known beyond all doubts, a person is admitted in the hospital, clinical diagnosis is made based on signs, symptoms, and diagnostic procedures, and death occurs due to natural consequence of the diagnosis, then you can certify the death, that such and such patient has died of myocardial infarction, pulmonary embolism, or whatever it is. But if you are not sure of the cause of the death, then don't certify the death. If the person is brought dead on arrival to casualty, or dies on arrival to casualty, person dying after admission and before making a diagnosis, and in all alleged cases of unnatural deaths like accidents, suicide, homicide, anesthetic deaths, snake bites, or death of woman in her husband's house within 7 years of marriage, please do not give a certified death certificate. It becomes a police case. And unfortunately, God forbid me, if any maternal death occurs in your hospital, suppose it is an atonic PPH, suppose it is an embolism, please do not certify a case and hand it over to the police and ask the police. It is the call of the police whether to do a post-mortem or not. Because unless and until you give a cause of death, police will not send the body to patients without doing a post-mortem. If you do not give the cause of death, police will take the due course of law, and that patient's body will be sent for post-mortem. And it is better to have a post-mortem done in case of unfortunate maternal death occurring in the hospital. Because if you certify the death and if you write that it is a postpartum hemorrhage, then the onus of proving that postpartum hemorrhage as a cause of death lies on you, and it will be a tough time for you to certify or to prove it in the court of law if something goes wrong or some medical legal case happens. So in case of table death or a postpartum death or a cesarean death, I would prefer that you do not certify the death. I mean, you certify the death, but do not give the cause of death, so that the patient will have to undergo postmortem and the due course of law will be taken. I think I have given a little justice to what was expected from me. I spoke on 3 to 4 topics. The medical legal topic is very vast. We have had 3 days complete conferences on all these topics. It was very difficult to complete everything in 20, 25, 30 minutes. But I think I covered all those topics. And thank you for giving me those opportunity. And the time permits, and with the permission of chairperson and organizers, I'm ready for question answers. Thank you.
I have got a question, Sudesh.
Yes, sir. Yes, sir.
May I ask you the question?
Yes, sir.
Supriya madam.
Yes, sir. Yes.
Routinely, before the changes in MTP Act law, we are used to advise anomaly scan between 16 to 20 weeks of gestation. Okay.
Yes, sir. Yes, sir.
And now, with the changes in MTP Act, and we got the permission to go up to 24 weeks.
Yes.
Can this period of advising anomaly scan change? I mean, can we routinely advise now anomaly scan between 22 to 24 weeks to detect more anomalies?
Yes, sir. Yes, sir. This has been the very crux of change in the MTP law. What Fox has been fighting for, because now with advent of ultrasound and availability of fetal medicine specialists and good machines, we can diagnose a lot of anomalies around 22 weeks. So now the recommendations for doing also is changing. They advise doing first a dating scan around 7 to 8 weeks. Then anomaly scan would be advised around 22 weeks. Why 22 weeks? Because and you want to do amniocentesis and you want to confirm the things, then you should have some buffer period of around 2 weeks. So instead of doing it 19 weeks, now I have done it a change that I do routinely anomaly scan, or I recommend, I don't do it, I'm not a fetal medicine specialist, but I recommend anomaly scans around 22 weeks.
Okay.
It's a very good thing, sir. You brought up this question and it was very
got
necessary.
that,
I will include this in the next talk. Thank you, sir, for that question. Thank you very much.
Okay. One more question regarding medical abortion, because medical abortions are being carried out routinely now in more number of cases, medical abortion.
Yes.
Prescription of medical abortion medicines.
Yeah.
The malpractices are going on at chemist level or sometimes at doctors levels. And medical abortion, you please talk something more about medical abortion and its rules. I mean, I am a consultant. I have only got OPD. I don't run my hospital.
Yes.
So can I prescribe? Can I do?
Yes, yes, sir. I will include that. Yes, sir. It was amended in 2003. It is almost 20 years ago. Now we had a difficulty. For example, Dr. Atnurkar sir is a freelancer. He has only OPD. He doesn't have an indoor hospital, or his hospital is not registered for MTP. Then a medical abortion can be prescribed by Dr. Atnurkar in his OPD, though his OPD is not registered under the MTP Act. How many times people in metropolitan cities, they don't have a hospital of their own. Their OPDs are somewhere, they're attached to some other hospitals. Then the MTP law has been made and extended. This amendment came long back in 2003 that if you are a qualified person to undertake MTP, you should be a registered medical practitioner with all those criteria A, B, C, C, A, and D that you are allowed to do MTP. Then in your OPD premises, you can prescribe medical abortion pills, but provided that you have a certificate in your OPD written that such and such hospital, which is a registered medical termination center, for example, a hospital around 500 or 1 kilometer away from you, which is a registered medical MTP center. Then if anything goes wrong or any complications occur, then that patient has to contact that hospital and the treatment would be done. This is for the safety of the patient, and they wanted to increase the scope of MTP, and they wanted to increase the MTP services, go more deep and in the periphery. That's why they did this amendment, and this can be done. Now, one more thing about malpractices. Now, this is very common in India, but the problem is who will bail the cat? For example, I know a person in the periphery, a general practitioner who has no qualification to do MTP, is prescribing medical abortion pills, or a pharmacy next to me is giving medical pills on the counter without doing anything. But do I go to the police and complain the police that such and such person, you try him under the Medical Abortion Act? No, we don't. That is our problem. But someone has to bail the cat. If FOCSO becomes proactive and at central level or state level or local level, if the FOCSO complains to the local health authority that such and such illegal medical termination is occurring at such and such place, then that authority may complain the police under the MTP Act. And it is not only the authority which you can directly file an FIR in the police, take action. You can file a complaint in the police that such and such things are happening, and it is crime in as per the rules and regulations of MTP Act.
Your voice was good. Thank you very much, Sudesh. Thank you.
Okay. So now may I have the comments of Dr. Anuradha ma'am, who is the president of Aurangabad Society.
Thank you, Supriya madam, for having me here. It was a wonderful talk by Dr. Doshi, and actually we every time when we know about medical legal problems, I think we need that reminder all the time in our practice. So I have one small question to doctor that if the patient has already received medical pills and she has incomplete abortion, and she has come to us. So in during that procedure, if something goes wrong or something is wrong with the patient's life, whether we are liable for that death or the person who has already given medical pills or MTP pills.
Yes, ma'am. There are 2 points. One thing is, if the patient gives specific history that such and such medical abortion pills were given by such and such person, then you can file a complaint against that person. If patient non-specifically tells that she has taken some abortifacients, then you mention that in the history, you make it a medical legal case, you inform the police, and then you treat the patient. But you have to treat the patient because it is an emergency, may it be medical, but you surely make it a medical legal case that and such, and in monthly reporting, monthly you report any complications of MTP in your HMS reporting, also an MTP report where there was any complication, then such complication should be reported in monthly reporting that this was a complication after MTP, though this MTP was not occurred at my center, but patient had taken abortifacient pills at some other place, unknown place. If you don't want to fight with the general practitioner, you can always make it anonymous that patient had taken pills from some person and now she has come with such and such things. But please make it a point to make it a medical legal case.
Okay, thank you. Thank you.
Thank you.
So, any more questions? I think is. So we.
Today, sir, just I want to ask one question.
Yes, sir.
If a lady go to a doctor, have a pills there, but did not terminate the pregnancy, okay? If she goes to another doctor, what is the procedure? What the doctor should do? Yeah.
First person is a registered medical practitioner. Hello? And he has.
Yeah. That is both are registered medical practitioner. Yes. She comes under all conditions of MTP. What is the procedure if she goes to another person having a live pregnancy in spite of having tablets?
One thing is that under good behavior, first thing we should inform our colleague that such and such patient, okay, no problem. And you will have to, you can perform an MTP for such a patient if she is well within the ambit of medical abortion. If you want, and if you can again try by medical abortion, or if not, you can undertake a surgical evacuation. If she has come to you, then in your MTP register, her name should be entered again and everything procedure should be followed. But if it is a failed medical abortion by you only, and she has come to you again for surgical evacuation, then her name may not be entered again, but you have to mention on the papers that such and such patient was given medical abortion, it was a failed medical abortion, and so I am doing a surgical abortion.
That's
the only thing is there should be no jostling what is said. What that doctor has done, he has given wrong pills, he has no experience. This should not be done. You should explain the patient that this is a known complication, 2 to 3% failure rate is known. This can happen with me also. Have good counseling him and then go ahead with the termination.
Yeah, thank you, sir. Thank you very much.
So I thank the speaker of the first session, Sir Sudesha, and also the chairpersons who have chaired and interacted so well, both the chairpersons. Thank you, sir. Now over to the second session, we have Dr. Gorak, but sir couldn't join. He is asking for the mail link, faculty link on his mail. So she'll connect. Can you help him out?
Yes, ma'am. We will try to connect to him.
He sent the mail ID on the group, on the WhatsApp group. Kindly see.
Yes, ma'am.
Yes. So we have our scientific convener, Dr. Nibha Mohan. She is also the Joint Secretary of Patna OBGY Society. So I hand over the platform to her to conduct this next session. Over to you, Nibhadi.
Thank you. Good evening, everyone. And thank you, organizers, especially Dr. Supriya Jaiswal, for giving me the opportunity and having me here as a convener of scientific session. So in this mixed bag webinar, we are having all important topics, and we just had a very important session of this medical legal issues, which is much needed today. So moving ahead to the next session, which will be with indemnity insurance and doctor. And the speaker will be Dr. Rahul Vani. Am I right, Supriya? Will be with this session, or Dr. Gorakh is there?
Dr. Gorakh will be there. He is just joining.
He has joined already.
Yeah.
Okay. Okay. Then we'll be having a second session, and the topic will be hypertensive diseases in pregnancy and preeclampsia. A very important topic. We need to be updated with this topic all the time. Whenever we get chance, we should be updated so that we can treat our patient with 100% and less of mortality with them. The speaker of this session will be Dr. Gorakh Mandrupkar, who is Secretary General of Justosis India Association. So welcome, sir. And to chair this important session, we have three beautiful ladies, three gynecologists. I can see all beautiful pictures in this flyer. So I think Dr. Vinita could not join.
Yes.
So the other chairperson, I wish to invite Dr. Sonali S. Bahadane, who's from Ahmednagar, and she is Honorary Secretary of the Society, Ahmednagar, Obs and Gynae Society. And she has been scientific committee member for AMOGS, Shirdi, and she has special interest in RPL, infertility, and colposcopy. And she has been awarded as COVID warrior as well by Lions Club. And she has been speaker for various national and local conferences. So welcome, Madam Dr. Sonali. And now I wish to invite Dr. Anjali Sachin Jama. She's President Solapur Obs and Gynae Society, and Madam is consultant at Jama Hospital and Laparoscopic Surgery Center since 20 years. And it's so important that it's the first laser, she's the first laser gynecological center in Solapur and up in the nearing areas. And she has been very active in her societies since last 7-8 years. She has been invited as faculty for conference as a cosmetic gynecologist, and she has delivered so many talks and different conferences, and she has delivered public speeches as well. So welcome, Madam Dr. Anjali. So over to you, chairpersons, to conduct this important session. So may I invite Dr. Sonali? Madam is there? Yes.
Yeah.
Madam, kindly introduce and invite Dr. Gorakh Mandrupkar.
Yes, ma'am. First of all, good evening to all of you. I would, at the onset, I would like to thank Patna Obs Gynec Society, Dr. Supriya ma'am, Dr. Vinita ma'am, Dr. Ajay Mane sir, Pardeshi sir, and all the organizers for giving me this opportunity. It's my immense pleasure to introduce our second speaker, Dr. Gorakh Mandrupkar. Sir is Secretary General of Justosis India Association. He is Director, MCHS, Center for Health Skills, Symbiosis International University. He is National Joint Secretary of POCSO. He is ex-chairperson, Chairman of Medical Disorders in Pregnancy Committee for POCSO. Sir is member Task Force National Policy on PPH of Government of India. He had also published 3 books, 12 publications, and more than 300 lectures. So we are glad to have a stalworthy like you, sir. Over to you, sir.
Right. Good evening, all of you, and I'm very sorry that I joined late. But actually, I was in travel and I stuck up in the traffic, so I could not go to my place and give the talk. But in the journey, while I'm in a journey, I will be talking. I'm very much thankful to Dr. Ajay Mane sir for inviting me here. And first of all, in advance, I will congratulate Dr. Supriya Jaiswal madam that yes, we are very much sure that you are going to win.
Thank you so much, sir. Thank you, sir. Thank you so much.
Right. So today we are going to actually discuss a very important topic, and that will be a gestosis score. Actually, I start saying that I owe my all these talks and whatever been introduced to my PG teacher, Dr. Sanjay Gupta sir. And when I was working under his leadership in Justice India Association, in that actually we developed this very important simple screening tool for the prediction and prevention of the hypertensive disorders of pregnancy. And this is now recognized as HTTP Justice score. And initially it was thought what it is, but now across the India, maximum number of the gynecologists, obstetricians, they are using it. We all know that actually existing chronic hypertension to the complex multisystem disorder like preeclampsia and leading to the complications like pulmonary edema, HELLP syndrome, eclampsia, stroke, left ventricular failure, they all are actually included in the HDP. Actually, in India, we do approximately 26 million deliveries per year. And we know our own data of the POCSO ICOG National Eclampsia Registry, it says that the incidence is 10.3%. So approximately almost we deliver 2.7 million cases per year. We deal with the hypertensive disorder cases. We know that incidence of eclampsia is 1.9%. So approximately almost 0.5 million cases of eclampsia per year we are dealing with. So it's a huge number. And WHO says that 90% of the maternal deaths are due to hypertension in pregnancy. So it becomes necessary that there is definite need to have the early and universal screening. Purposefully, I'm using the word screening here because initially we used to say there has to be certain method for the prediction and etc. But when we start using the words like prediction, etc., then the topic becomes dilute. And when we use the word universal screening, then we understand yes, there is a great necessity to do for each and every pregnant woman in India. And in India, it is a gigantic task to do all. If we see what are the suggested prediction methods, then there are n number of methods which are based on, say, placental perfusion, vascular resistant dysfunction, or methods which are available on fetoplacental unit dysfunction. You are seeing there, right, from rollover to halpa fibronectin, Doppler ultrasound to activin A and whatnot. Next, please. Then there are another methods. Next, please. Yes, which are based on before that, sir. So there are n number of tests, like say, which are based on renal perfusion even. Then there are certain tests which are suggested based on the immunological workup, right? So there are n number of tests, but all the clinical researchers, they have found out that none of the tests out of these more than, say, there are, next please, more than 60 tests, out of them, none of the tests is found to be reliable as a single test for the prediction. And that's why the prediction based on the assessment of clinical risk factors is recommended. Next, please. But this paper stirred a lot. Actually, this paper is that is nothing but a SPREE, and SPREE is not a trial. Actually, it is a regression analysis. And what they did, it was a Leona pool and the group, and they did a comparison of diagnostic accuracy of early screening or the preeclampsia by the NICE guideline. And what they gave, okay, when you do, MF is a maternal factor, MAP is a mean arterial pressure, then we all know PAPE, we all know PLGF. So if you see, concentrate on the last line, then you will find out that they say that you do the screening by using maternal factors as well as mean arterial pressure, uterine artery Doppler, PAPE, then PLGF, and then together the detection rate may go up to 81%. But to say, to write down in a paper, it is fine. What is the practicality? Next, please. So it cannot be a routine screening procedure because this is mere a regression analysis. And the guidelines, even like say American guidelines or NICE guidelines, or even Australian health department guidelines, or even our own FOCSI ICOG gestosis guidelines, they say that no, it is impracticable. And in India, we thought, chalo, as what they say, let us start do the screening, and then we find out, chalo, what is the budget? Say, for example, in my city, I have taken the example of my Islampur own city, the Doppler may be 2,000 rupees. I have not quoted about metros. Then all biomarkers may be 6,000. So together, each and every patient, the budget will be 8,000 rupees per patient just for screening. And when we are saying it is a universal screening, that means it has to be applicable to all of the India. So let us multiply 8,000 by those 27 million, and the budget will be 2,800 crore per year. And then I found out that the total National Health Mission budget is 28,000 crore. So it will be 1/10 of the total allocation to the whole National Health Mission fund. Is it practicable? No. Even the United States Preventive Services Task Force, they say that it is not possible even for United States to screen with this much methodology because United States doesn't have sufficient funds. So if US is saying that, what about India? And that's why all of these guidelines, they say that clinical risk-based factor screening is must. And then the question was asked, can we simplify the screening? And the answer is yes. We can simplify, and that's how this HDP gestosis score came. And what it is nothing but a simplified, dynamic, feasible quantification of maternal risk factors for the effective screening of hypertensive disorders of pregnancy. And proud to say that developed by myself, and it was modified by, again, the team of Dr. Sanjay Gupta sir, Dr. Suchitra Pandit, Dr. Girija Wagh, and Dr. Alpesh Gandhi. And now it is accepted by the FOCSI ICOG gestosis good clinical practice recommendations. And soon it will be coming in Mann Ki Baat, and then probably all India will be using this. So how we do this calculation of the gestosis score? A simple thing is done. We found out the risk factors which are responsible for Indian women to attribute them that she will be at risk to develop the preeclampsia or at risk to develop the hypertensive disorders of pregnancy. And we actually segregated them into mild risk factors, moderate risk factors, and high risk factors. And you all know that even NICE guideline, the UK guideline, they have given likewise. Even US guideline, they have given likewise. And here we did the quantification. So number one is attributed, or value 1 is attributed to the mild risk factor. Value 2 is attributed to the moderate risk factors. And value 3 is attributed to the high risk factor. And we say that, let us have the one question here. And now we have simplified it by making it as an app, so that if when we interview the patient with those 27 questions, then we will come to know which risk factor is present in that lady. And depending upon that, we have to tick it, or we have to just press yes, no. And at the end of the usage of the app, we will come to know what is the summation of the score. And when the summation of total score exceeds more than 3, then we say that women is at risk to develop the preeclampsia. In front of you are the mild risk factors, right? So you all know age older than 35, age less than 19, then the maternal anemia, obesity. Again, for Indian women, when the BMI is more than 30, it is a mild risk factor. But as soon as the Indian women goes with BMI more than 35, it will be moderate risk factor. We all know primary gravidas, yes, they are at risk. The short duration of cohabitation, that means she is recently married and she is planning the pregnancy within the 6 months of the pregnancy. Yes, she is at risk. Polycystic ovary syndrome. Then even if it is if she is a second gravida or more than that, and the inter-pregnancy interval is more than 7 years, then the body will recognize this second pregnancy as if a first. And that's why it will have a high risk. Mean arterial pressure more than 85. Then those families who are having dyslipidemias, the cholesterol is very high in families. Then excessive weight gain during the pregnancy. So all these are mild risk factors. Then there are moderate risk factors. We all know whenever we are talking, we are giving the lecture of hypothyroidism, we say that it is high risk. But when our patient is primary gravida along with subclinical hypothyroidism, probably we are not looking towards that patient as a high risk. But we must, because she is clinical. I'm sorry, I got disconnected. Yes, I'm back. So when she is having that, say, subclinical hypothyroidism and primary gravida, her risk factor will become 3. Then even if she has a family history of preeclampsia, the first degree relative, her sister, her mother, her maternal auntie, that means Mausi, then she is at risk. Gestational diabetes mellitus, obesity. Here I have taken for the Indian women BMI more than 35. So like Caucasian women, like Western women, we should not consider the BMI more than 35 or 40. Our Indian women say, one thing you must know. In Pune, there is a great researcher, Dr. Yajnik, and he has maximum papers on it, and he has brought out a very good concept, and that is of thin, fatty Indians. As you all know, on the screen you are looking me, I'm a 45-year-old man with this much BMI, maybe I'm 165 height, having weight 65. So I may be ideal for that BMI point of view, right? But I'm a thin, fatty Indian. That means though I am thin, I'm having high fat index. Our Indian women, they are 11 times high risk to develop GDM, to develop hypertension. That concept we have to keep in mind in comparison with the Caucasian women. Multiple pregnancy, another risk factor. Hypertensive disease during previous pregnancy is another risk factor. The next are high risk factors, and they are known case of diabetes, chronic hypertension, then even thrombophilias, then the autoimmune disorders, or OD, or even surrogacy pregnancies. So even single factor out of these 7 factors is present, it should be considered that women is very high risk to develop hypertension. Next, please. And then we calculate it. If total is more than or equal to 3, the pregnant woman is marked as at risk for hypertension, and it is our duty to inform that woman, to mark on ANC paper, and to discuss with them that yes, there is a problem. We have to discuss with them the diet, the exercise, and what are the preventive measures we are going to use with them. And what are they? The very simple thing, next please, is aspirin 75 milligram at bedtime, 20 पैसा में मैं ऑलवेज बोलता हूँ कि ये 20 पैसे का टैबलेट है और ये हमारी जान बचाएगा. 20 पैसे का टैबलेट along with elemental calcium 1 to 1.5 gram in divided doses. Along with that, low carbohydrate diet, high protein diet, no need of salt restriction, but pinch of a salt. Whenever you use the salt, we have to use in pinch, right? Then अभी आप सब लोग वहाँ पे सोचते होंगे कि अरे ये 75 बोल रहा है, जबकि whole world is talking about 150. No, I am giving the explanation to that. Aspirin, when to start? It is to be started as early as possible from the day the risk is attributed. It might be the day 1 of the pregnancy. It might be the first week of pregnancy. But still we have to start. Yes, any problem? Any problem? Mane sir?
No, sir. No, sir. No problem.
Okay, I'm sorry. Right. Please tell me if I am exceeding the time, but I think I am not, because last 7 slides are there. Right.
Yes.
So, sir, previous slide, please. Yes. The defective placentation, as we all know, it is a causative factor. Right. So there is a defective trophoblastic invasion. And when this trophoblastic invasion occurs, we all know 6 to 8 weeks of pregnancy. Second wave will come when it will come in for 12 to 14 weeks of pregnancy. So वहां पे अपसेट होगा और आप बाद में उसे स्क्रीन करते बैठोगे, आप 13 वीक्स पे स्क्रीन करते बैठोगे, आप 28 वीक्स पे स्क्रीनिंग करते बैठोगे, कुछ फायदा नहीं. You will start the intervention after the NT scan, कुछ फायदा नहीं. So ideally the aspirin has to be started as early as possible, because it will cause the balance between the thromboxane A2 and prostacyclin. And that's how it will maintain the adequate placental perfusion, and that's how it will prevent the preeclampsia. Then till which day we have to continue? Next, please. We have to continue the aspirin is to be continued till 48 hours prior the labor induction or the delivery. Right? Please do not do I, me, my business. Right? Because I feel like that. I have read somewhere. I have heard somewhere. हमारे unit में हमारी मैडम ऐसे किया करती थी. No, nothing doing. We have to follow the guidelines. And the guideline says that aspirin should be continued till 2 days or 48 hours prior the labor induction or the delivery. That is very important. Then what should be the dose? Again, I have said that there are n number of trials which are been there. They have used 60 milligram, they have used 75, they have used 81, they have used 100, they have used 150. But the patients which are exposed to the dose of more than 100 in the world, they are very less. I have gone through at least 85 papers. And then everybody accepts that the aspirin 75 milligram, it is easily available and that has to be used. Then somebody will say, nowadays the fetal medicine people, they say 150 milligram. But it is based only on one paper. Please read that paper. What is that paper? That paper says that we have done the screening of 26,000 people, 26,000 women. But please read carefully. Out of them, they could find the positive screening in maybe some around about 1,200 or 1,300 people, women. Out of them, 50% women, they were given placebo, and 50% women, they were given 150 aspirin. So they have not compared the 75 and 150 dose, but they have compared it with the placebo. So it's a bias. Another thing, those 1,200 or 1,300 women, they were from 70 countries. तो हर एक कंट्री का कितना आया 2 या 10 आ गया. Then maximum women, they were Caucasian. Indian and African women were not there. Maximum women were having chronic hypertension. Maximum. So this is a biased study. I say it right, and now I know that this webinar has been recorded. I know. So whatever I'm talking is with responsibility. So please, we have to consider about the Indian women. And 75 milligram bedtime daily till 2 days prior induction or delivery is the ideal thing. Next, please. What about the calcium? Yes. Why calcium? I have given the explanation. Because calcium supplement, it prevents the endothelial cell activation. And how much? Elemental calcium, 1 to 1.5 gram. That is very important. Just एक कौन सा 250 का टैबलेट दिया, एक 500 का टैबलेट दिया, ऐसा मत कीजिए. We have to give 1 gram minimum to maximum 1.5 to 2 gram. Even WHO says like that. WHO says that the calcium has to be supplied in the calcium poor settings, right? So do you agree, madam? Everybody will agree कि क्या हमारे डॉक्टर लोग भी क्या 2-2 गिलास दूध पीते हैं? क्या हमारे डॉक्टर लोग भी रोज 2 अंडे खाते हैं? So if affluent society is not taking sufficient calcium, then what about our patients? So this much dose is sufficient and required. Next, please. Maybe last 4 or 5 slides. I am saying again and again that scoring system is dynamic. आपने 13 या 14 weeks पे एक स्कैन कर दिया, एक ब्लड का इन्वेस्टिगेशन कर दिया, छोड़ दिया. This scoring system is not like that. It is simply, there are simplified additions. आप लास्ट लाइन पे देखो, there are 5 factors like anemia का assessment, GDM का assessment, weight gain का assessment, thyroid का assessment. All these things, they are going to changing, right, during the each visit. So आपके जो 22 factors है, they are constant. लेकिन ये 5 factors है जो आपको हर एक visit पे दिखाई देंगे. तो समझो हमने वो लेडी का स्कोर किया और आज हमें मिला 2, लेकिन बाद में जो 24 वीक्स पे आई और हमें वहां पे दिखाई दिया कि ओ हर MAP is more than 85. So probably now her initial risk factor was 2, but now from today she has become 3. So from that day we can start aspirin. From that day we can add the calcium. तो कोई बोलेगा कि क्या लेट कैल्शियम और एस्पिरिन देने से कुछ फायदा होगा? Yes, फायदा होगा, because studies have shown that though we may not prevent the preeclampsia, but definitely we can reduce the complications of preeclampsia. And that's why this scoring system is dynamic. और इसका खर्चा कितना आएगा? 0 पैसा. इसको टाइम कितना लगेगा? बस डाउनलोड करने में आपको अभी जितना टाइम लगेगा ना. तो इट इज माय सिंसियर रिक्वेस्ट कि ये लेक्चर तुरंत होने के बाद देखते देखते यू कैन गो ऑन द स्प्लिट स्क्रीन, गो ऑन द एंड्रॉइड ऐप स्टोर और वहां पे आप इसे डाउनलोड कर सकते हो. यू विल गेट 10 seconds, 0 पैसा, राइट, बिकॉज आई हैव डन एक्चुअली करार मैंने गूगल के साथ किया है, तो वो पैसा भी नहीं लगेगा, इसमें आपको कोई एडवर्टाइज भी नहीं आएगा. और जब आप इसे यूज करते बैठोगे ना, तो ऑटोमेटिकली मेल विल बी जनरेटेड. एक मेल आपको जाएगा, and even you can take a print out of it and you can give it to the patient, and that will be the medical legal document कि हमने आपको स्क्रीन किया, हमने आपको रिस्क फैक्टर बोला और हमने आपको बोला है कि एस्पिरिन ले लो, ये कैल्शियम ले लो, कार्बोहाइड्रेट कम खाओ. तो दैट बिकम्स इवन अ सिंपल मेडिकल लीगल डॉक्यूमेंट. हाँ, उसको 50 पैसे का खर्चा आएगा, दैट्स इट. वो एक जेरोक्स निकाल लेंगे, बस दैट्स इट. वो 8,000 किधर है और ये 50 पैसा किधर है? Are there clinical evidences? Yes, each clinical risk factor has good quality evidence. और हमने भी 26,000 28,000 नहीं, अभी देखिए ये मेटा एनालिसिस कितने लोगों का है. 92 स्टडीज कंप्राइजिंग ऑफ 2 करोड़ 53 लाख 56,688 प्रेगनेंसीज इन 27 countries. So I think data is sufficient, right? So the rationale is given with the 2 crore patients. Yes. Next, each slide is giving regarding the attributable risk and regarding the risk, individual risk, right? Next, please. So I think the 3-4 slides आप sir skip करते जाइए. Next, please. Yes. So these are the FOCSI, Gestosis, ICOG guidelines, and I was fortunate and I was blessed that I was given opportunity to draft these guidelines for India, of course, under the leadership of Dr. Sanjay Gupte, Dr. Suchitra Pandit, and Dr. Nandita Palshetkar. And now this is an Android app. तो अभी मैं मेरा स्क्रीन शेयर करूंगा और आपको एक केस दिखाऊंगा, and then I will end up my lecture. So this will take just 1 minute. So I am sharing my screen. Please allow me to share the screen. Can I? Right. So yes, I'm going on. Yes, I'm going on my screen. Start now. Right. So, are you able to see my screen?
Yes, sir. Yes, sir.
तो ये HDP जस्टिस स्कोर हमने निकाला. हमें लिखना है डॉक्टर का नाम. तो चलिए हम डॉक्टर का नाम लिखते हैं जेम्स. I have to put my email ID. हमने डाल दिया. केस पेपर नंबर 007. पेशेंट का नेम बॉन्ड. तो अच्छा खासा पेशेंट बन गया. स्टार्टिंग. सो मैं सुप्रिया जायसवाल मैडम जी से रिक्वेस्ट करूंगा कि आप आपके मन में एक पेशेंट रखिए, एज इफ यू आर स्क्रीनिंग दैट पेशेंट, राइट? सो जो भी 27 क्वेश्चंस है, आवर टाइम स्टार्ट्स नाउ. It will take just 1 minute and we are going to save the life of a woman, right? तो आपके सामने एक पेशेंट पकड़िए and tell me what is the age of her that patient. Supriya madam.
This one. Age older than 35 years.
Okay, yes.
36.
So ये younger चला गया. Whether she is having maternal anemia?
Yes.
Yes. आप देखिए ये जो भी आपको स्क्रीन दिख रहा है, that is yellow background और उसके right upper corner में लिखा है mild risk.
Yes.
Whether she is having obesity?
Yes.
Yes. Next. Whether she is primary?
Yes, she is primary.
Okay. Short duration of sperm exposure. उसकी शादी को 6 महीना नहीं हुआ है ना? ज्यादा हुआ.
हाँ, ज्यादा हुआ है, ज्यादा हुआ है.
Whether that woman was born at small for gestational age? उसकी मम्मी को पूछा तो उसने मम्मी ने बोला नहीं 4 किलो की थी.
नो.
So क्या फैमिली हिस्ट्री में किसी को अटैक स्ट्रोक है? मम्मी ने बोला नहीं, हम तो अच्छे खासे हैं. क्या पॉलीसिस्टिक ओवरी सिंड्रोम है? तो नहीं. खासी स्लेंडर लेडी है. देन प्राइमी है तो इंटर प्रेगनेंसी इंटरवल चला गया. आईवीएफ इक्सी भी ये नहीं था. उसका एमएपी हमने फर्स्ट विजिट पे देखा. So she was having blood pressure 120/80. MAP normal है, right?
Yes.
Yes. और उसके घर में तो किसी को डिसलिपिडेमिया वगैरह नहीं था.
नहीं.
एक्सेसिव वेट गेन का ये विजिट पे सवाल नहीं, बिकॉज इट इज फर्स्ट विजिट.
Yes.
अभी देखिए स्क्रीन का कलर चेंज हो गया और दिस बिकम्स ऑरेंज और अपर क्वाड्रेंट में आ गया मॉडरेट रिस्क. तो हमें ये भी बताता है कि ये थोड़ा सा कुछ आगे जा रहा है. तो whether this patient is having hypothyroidism?
No.
Thin slender lady? No. Family history of preeclampsia?
She didn't give any history. No.
Okay, so no. क्या उसको अभी जीडीएम है? आपने जीसीटी किया लेकिन उसको जीडीएम मिला या नहीं मिला?
नहीं मिला.
नहीं मिला. ओके, ग्रेट. ओबेसिटी तो नहीं है. वो 30 के आगे है लेकिन 35 से कम है कि ज्यादा है?
कम है.
कम है जी. ओके, फाइन. Whether it is twins or multifetal?
Twins.
No, twins है. ओके, फाइन. चलिए twins है. ड्यूरिंग प्रीवियस प्रेगनेंसी का सवाल ही नहीं. अभी देखिए स्क्रीन का कलर रेड हो गया और अपर एंड क्वाड्रेंट में आ गया हाई रिस्क. राइट. स्क्रीन ने बता दिया कि केयरफुली पूछो. तो क्या उसे पहले से डायबिटीज है? नहीं. क्या वेदर शी इज अ नोन केस ऑफ क्रॉनिक हाइपरटेंशन?
नो.
नहीं. कोई मेंटल डिसऑर्डर है कि जिसके लिए उसे ट्रीटमेंट चालू है?
नो.
नहीं. कोई उसे इनहेरिटेड या एक्वायर्ड थ्रोम्बोफिलिया है, प्रोटीन सीएस डेफिशिएंसी वगैरह?
नो सर. नो.
नहीं. मैटरनल क्रॉनिक किडनी डिसीज? नहीं. कोई एसएलई एप्लास वगैरह है? नहीं. वेदर इट वाज आईवीएफ इक्सी प्रेगनेंसी? नहीं. अभी हमें बटन दबाना है सबमिट का एंड करिश्मा देखिए सामने आ गया. केस पेपर नंबर 007, पेशेंट का नेम बॉन्ड, HDP जेस्टोसिस स्कोर 6 और स्क्रीन ने बता दिया कि शी हैज माइल्ड 4 रिस्क फैक्टर्स और एक मॉडरेट वाला रिस्क फैक्टर है. एंड स्क्रीन बताता है कि स्कोर ऑफ मिसेस बॉन्ड इज 6 which indicates that she is at risk for developing HDP. Please start aspirin 75 milligram daily after dinner, calcium 1 gram daily. In bracket again it is giving once or in divided doses. और आगे 2 इंपॉर्टेंट इंस्ट्रक्शन वो बता रहा है कि प्लीज मॉनिटर हर ब्लड प्रेशर इन सिटिंग पोजीशन ड्यूरिंग एवरी विजिट. दैट मींस आपकी पेशेंट को अभी तो ब्लड प्रेशर नहीं डेवलप हुआ है लेकिन आपको अच्छा खासा उसे मॉनिटर करना पड़ेगा. और कैसे मॉनिटर कीजिएगा? तो उसका हर एक विजिट पे आपको देखना है. डोंट रिलाई ऑन द नर्सेस या उनका अच्छी तरह से ट्रेनिंग लीजिए. जो आप बीपी मॉनिटर यूज करोगी वो अच्छा खासा कैलिब्रेटेड होना चाहिए. आइडियली वो मर्क्यूरी मैनोमीटर होना चाहिए. अगर मर्क्यूरी मैनोमीटर नहीं है, आप एंड्रॉइड यूज कर रहे हो, आप इलेक्ट्रॉनिक यूज कर रहे हो, इट हैज टू बी कैलिब्रेटेड, तभी वो सही आएगा. और आगे बता रहा है कि काइंडली इन्फॉर्म हर अबाउट द रिस्क एंड प्रिवेंशन स्ट्रेटजीज. राइट. अभी क्या हुआ? अभी आपने स्क्रीन पे देखा कि मुझे कुछ मेल आ गया. तो चलिए मेल पे चलते हैं क्योंकि वो ऑटोमेटिकली गया. देखिए ये मेल आ गया HDP जेस्टोसिस स्कोर। मैं मेल भी खोल रहा हूँ, यू आर लुकिंग ऑन माय स्क्रीन। देखिए ये ऑटोमेटिक सर्वर से आपको मेल आ गया। डेट भी बता रहा है कि 19 अप्रैल को आपने 6:40 36 पे जेम्स पेशेंट से बात की डॉक्टर ने। और ये देखिए, और ये नीचे पूरा मेल आ गया, और ये मेल में दिखा रहा है कि जो भी फैक्टर्स आपके पॉजिटिव है ये बोल्ड में दिखाई दे रहे हैं, और जो भी फैक्टर्स उनके नेगेटिव है ये ऐसे ही है। So this is how we take a printout and we can give it to the patient. So this is the beauty of this code. जब आप पहले पेज पे जाते हो तो यहाँ पे there is about HDP जेस्टोसिस स्कोर आता है, जिसमें लिखा गया है कि किसने डेवलप किया, मॉडिफाइड बाय द टीम, ये प्रोसेस ऑफ रिपोर्टिंग क्या है। और नीचे यहाँ पे भी आपको दिख रहा है 2019 POCSO ICOJ जेस्टोसिस GCPR। आप इस पे अगर फिंगर लगाते हो तो ये गूगल पे आपको लेके जाएगा डायरेक्टली गाइडलाइंस पे। देखिए वी आर गोइंग ऑन ICOJonline.org। ये देखिए हम डायरेक्टली आ गए फॉक्सी के पेज पे, जहाँ पे आपको डायरेक्टली गाइडलाइन मिल जाएगी। तो वी वांट टू शो यू दैट कि जो भी हम बात यहाँ पे कर रहे हैं, इट हैज एब्सोल्युटली each and every word, each and every line has evidence. So we are talking everything with sense, with evidence, and with the motto that each single Indian woman's life should be saved, and that too without a क्या बोल सकते हैं, ज्यादा पैसा देने के बजाय। तो पैसा नहीं देना चाहिए, और सादा सिंपल 20 पैसे का टैबलेट एस्पिरिन का दे दीजिए, कैल्शियम दे दीजिए, अच्छा खासा उसे बात कीजिए, उसे क्या खाना है क्या नहीं खाना है बोलिए। We can save the life. We can reduce the maternal mortality of the India. So, it is my sincere request that please download this core, use it, and we are not saying that we are God. Yes, इसके आगे कुछ नहीं है. No, we are open for discussion. In fact, हम बोल रहे हैं कि आप ज्यादा से ज्यादा स्टडी करो, जिसमें कुछ आपको गलतियां लगे आप बताओ। आपके एरिया के बारे में अगर कुछ अलग रिस्क फैक्टर्स आपको लग रहे हैं, प्लीज राइट डाउन टू अस सो दैट So even in fact I am seeing that 1 साल के बाद शायद मॉडिफाइड HDP जेस्टोसिस स्कोर आ जाए, I will be happy, क्योंकि we are open for discussion। एक भी माता मरनी नहीं चाहिए, वो बचनी चाहिए। So this is our motto। Thank you once again। I am very much thankful to the newly elected vice president of POCSO, Dr. Ajay Mane sir, because I am very much lucky that actually he is running the slides for me, right? तो ऐसा कृष्ण मिले तो शायद मेरे जैसा कुछ अर्जुन कुछ कर सकता है, right? So I am very much thankful to him. Otherwise, during journey it was not possible for me to run the slides and all. And फिर भी मैं आपको बताता हूँ 10 किलोमीटर का डिस्टेंस इन दिस मच चाहिए, तो घर जाके तो it was not possible for me, right? So thank you very much again. Over to you. I am open for discussion. Thank you.
Thank you, sir. Thank you very much. Closing remarks, Anjali, Dr. Anjali.
Good evening, all.
Dr. Anjali, yes, please put your closing remarks.
Thank you, Patna Society, for giving me this opportunity. Sir, you have really nicely explained nice guidelines, attitude, approach, and acceptance towards HDP. And your brainchild HDP Justice score, excellent tool. Very well explained, even HDP budget. Why to use 75 milligram ecosprin, when to start and when to stop, clear-cut take-home message you have given, role of calcium and dose. We will definitely start using Justosis app, which you have explained thoroughly.
Yes.
Thank you very much.
Thank you very much, madam. It is my appeal to all that please, I am not saying bad, the foreign guidelines are bad, but I am always requesting our Indian doctors that guidelines which are made for Indian women by the Indian doctors, they should be used because they are money for that, right? Thank you very much.
Thank you so much, Dr. Gaurav, and very nice talk. we were aware about the score, but the app you had shown, it's really, nice. And it's so easy to use also. And we'll definitely use it routinely.
Thank you very much.
Thank you for letting us know that. And
Yes.
thank you both the chairpersons for your nice inputs. So thank
A
you.
word from me. Thank you, Dr. Gorak, for joining from while you are on the way. Thank you so much. And thank you, the beautiful chairpersons, Dr. Sonali and Dr. Anjali, for giving your inputs and coming over here. Thank you so much. Thank you.
Thank you.
Thank you, Supriya Madam. Once again for the opportunity.
Yeah, it was lovely connecting to you people.
Yes, ma'am. Same here.
Thank you.
Okay, that's the end of this beautiful session. So moving ahead to the third session, that's equally very important, indemnity insurance and doctor. And we need safety of ourselves. So very important topic again. The speaker is none other than Dr. Rahul Vani, who will be presenting this important talk. To chair this session, we have three brilliant gynecologists from different places. First, may I invite Dr. Rajesh Kokare. He's from Baramati, IVF consultant, President Baramati Ops and Gynae Society, and worked as West Zone Coordinator, Safe Motherhood Committee, FOCSO. And he has much contributions in anemia and adolescent health. Was nominated for Anandibai Gaurav Puraskar and appreciated by PMO for contribution in rural women health. So welcome, Dr. Rajesh.
Good evening. Good evening, ma'am.
Good evening. And now I wish to invite Dr. Nandini Vadya Bhagat, who is President, Hingoli OBGY Society. In the next few 2 hours, and she's consultant obstetrician and gynecologist at Davda Nagar, Hingoli. She's director Bhagat Hospital as well, and she's university topper in first MBBS, past vice president IMA Hingoli, and she has special interest in women health in rural areas. So welcome, madam. Now I wish to invite Dr. Pranita Jatpe. She's past secretary, Hingoli. So over to chairpersons to conduct this important session. May I invite Dr. Rajesh? Is he there?
Yeah, ma'am.
He's there. He's there.
Please introduce and invite the speaker, Dr. Rahul Vani, sir.
There is. Hello. Can I request someone else to do it because there's some issue with the range.
Okay. Is madam there?
Dr. Nandini is there.
Yeah, please.
Dr. Nandini?
Yeah. Nandini, yeah,
Yes.
please.
Okay. Please introduce and invite, sir, Dr. Rahul Vani.
Yes. Good evening, everyone. Ma'am?
Yeah,
Yes,
you're audible.
Yes. Good evening, everyone. I extend my warm regards to today's chief guest, respected Dr. P.K. Shah, sir, Dr. Rishikesh Pai, sir, today's guest of honor, Dr. Rajendra Singh Pradesi, sir, Dr. Ajay Mane, sir, Dr. Sarita Bhalera, ma'am, President MUGS, Dr. Suvarna Khadilkar, ma'am, Secretary MUGS, today's organizing team, Dr. Sunil Singh, ma'am, President Patna OBGY Society, Dr. Supriya, Secretary Patna OBGY Society, and all the speakers and chairperson, and of course, everyone who is there in today's informative webinar. Very good evening to everyone. Today, I am deeply humbled and honored to be part of this informative webinar. I am extremely thankful to Supriya Jaiswal madam who make me all the efforts and giving me this opportunity to be the part of this burning current topic of today's scenario. Our next topic, indemnity insurance. Doctor. Before coming to the topic of discussion, I would like to not miss the opportunity to pay my heartfelt condolence to one of our faculty members, late Dr. Archana Sharma from Rajasthan. At the same time, I would like to congratulate and thankful to our National POCSO Office bearer team, President Dr. Janda Madam and Dr. Madhuri Patel ma'am. Also, Dr. Rajendra Pardesi sir and Dr. Ajay Mani sir, who took all the efforts, who took all the initiative to give justice to Dr. Archana Sharma from Rajasthan and Dr. Nilesh Maske from Ahmednagar, Maharashtra, making me realize the power of our unity in the organization, the FOX. Coming to the today's topic, that is indemnity insurance and the doctor, I must say it's a very important issue in today's situation. As a medical practitioner, anyone faces allegations of malpractice, negligence, misdiagnosis, incorrect treatment, a professional indemnity insurance policy will provide coverage to protect our finances. Its purpose to just and does Dr. Rahul Vani, sir. Please start the session, sir.
Good evening, everyone. Thank you, organizers, for giving me this opportunity, and my wishes to all the seniors here, Dr. P.K. Shah, Dr. Rajendra Singh Pardesi, Dr. Ajay Mane, Dr. Rishikesh Pai. Can I share my screen? Am I audible?
Yes, sir.
Yes.
Yeah. I'm actually out of town, and I'm
You are not audible.
Hello?
Is my screen visible?
Yes.
Yes, sir. Yes, sir.
I think my this is not moving slides. I'll stop sharing and I'll start sharing again. So let me start sharing again. No, my slides are not moving.
सर तुमचं कनेक्शन अनस्टेबल वाटतंय.
By this time, I would like to introduce a few words about Dr. Rahul Vani, sir. Dr. Rahul Vani, sir, is President, Navi Mumbai OBGY Society. Sir is having 17 years of experience in obstetric and gynecology, medical consultant associated with the medical consultancies. Dr. Vani, sir, is a honorable consultant, Mathadi Hospital Trust. Sir is member of Medical Legal and Ethics Committee, FOCSO. You can start your session, sir.
Yeah. So I'll be talking about professional indemnity. Now, as you all know, professional indemnity is very important for all the practicing doctors. Without professional indemnity, practicing is like a graveyard. You can fall into trouble anytime. Now, what I will be talking in indemnity insurance or professional indemnity is I'll be covering these points. What is indemnity? What is indemnity insurance? Why should we have indemnity insurance? Now, is indemnity insurance mandatory? How much cover should we have? And what is covered? What is not covered? When one individual takes on the obligation to pay for any loss or damage that has been or might be incurred by any other individual. So this is a definition which has been given in the Indian Contract Act. So it is a contract by which one party promises to save the other from loss caused to him by conduct of the promisor or by the conduct of any other person. So one thing important to note here is it is a conduct of a person, and it is not any natural calamity which occurs where this indemnity insurance will work. Like natural calamities like earthquakes or say a downpour like cloudburst, if there is any loss because of the natural calamities, indemnity insurance will not cover that. It is an act of an individual which is covered by the indemnity. Now, since it is a contract, all the elements of a valid agreement are applicable to indemnity insurance. That means the parties should be competent to contract. Competent means age. He should be a major. He should be sane in mind. Insane person cannot enter a contract. The contract has to be a free consent. It should not be forced. It should not be with misrepresentation. So all the elements of a valid contract or valid agreement are applicable to this, and consideration of this contract should be for a lawful object. Now, the person who gives this indemnity is called the indemnifier. So in our case, the insurance company is the indemnifier and we are the indemnity holder. So in case any losses occurred or if there's a case against us, and then if we claim, we are called as the indemnity holder. Now, what is indemnity insurance? In short, for our medical practice, what is indemnity insurance? So indemnity insurance is a type of a liability insurance. So in case a medical legal case is filed against you, if you have indemnity insurance, the insurance company will pay for the compensation. If compensation is awarded against you, depending upon the cover you have. So they are not going to pay whatever is the cost, depending upon your cover, with the cover which you have taken. Now, suppose you have taken a cover of only 10 lakhs and the award against you is 20 lakhs. So the insurance company will pay only 10 lakhs. The rest of the money you will have to share. So it also depends on the cover you have taken. Now, why should we have professional indemnity? Now, survey conducted by the National Law University, Bengaluru said there is 400% rise in litigations, especially against doctors. The cases are rising every day. Times of India said there is 110% increase in cases. And compensation awarded is uncertain. In some cases, it may be in crores. Even if the case is frivolous and you are definite you will win it, but even if a single case is filed against you, you might have to pay in lakhs as lawyers' fees. So that also could be very expensive to your pocket. Now, why should we have professional indemnity? Professional indemnity allows a business to offer services without having to build in the potential additional cost of any mistakes they might face in the future. Now, in reality, mistakes do happen, regardless of any industry in which you are working, regardless how long you have been working. Is mandatory? No, it is not mandatory. Now, if you are willing to pay from your pocket, you might as well do it. Start your own insurance, like add premium to your patient's bill and invest the amount and pay from this fund whenever there is a claim. But the claim amount is so uncertain that you will not know how much premium you need to add on the patient's bill, and whether you will be able to collect that fund or that much amount or corpus to pay up this bill. Because as you know, in a famous case of Kunal Shah, the compensation was in crores. Now, how much cover should we have? Now, compensation awarded does not depend on your earnings. Now, it is based on how much your patient was earning, the potential active years of his earning, the potential increments in his earning, and the mental agony and sufferings to the family, loss of companionship to the family.
His connectivity is gone a little bit, no?
Minimum of 1 crore, and for hospitals, minimum of 2 to 5 crores. And if you have a very high case load, you should have a higher cover. Now, indemnity for establishment and personal. Indemnity for establishment and personal insurance. So you should have both these covers. Now, if you have only establishment cover, your medical negligence cases or indemnity will be covered only if you are working in that hospital. But if you have a personal cover, wherever you are practicing or whichever hospital you visit as a visiting consultant, or if you go to assist somebody and the medical negligence case arises against you, so your personal cover will cover you for all this, wherever you practice. So it is important to have both these insurances, the establishment cover as well as a personal cover. Now, establishment cover will also cover your employees, your staff, nursing staff, your unqualified this. What is covered when you take an indemnity insurance? Your defense cost, third party damages, breach of confidentiality, defamation, libel and slander like loss of documents, and claims arising out of professional services, any bodily injury, death, dishonesty, runoff. I'll explain what is runoff a little later. And if reappeal security deposit, that means if a case is filed against you, it goes against you and you want to appeal against this case. So when you appeal, the court asks you to deposit a certain amount before you can appeal. So this reappeal security deposit can also be claimed from this insurance. Now the current policy offered by FOCSO is very good. It is by the ICICI Lombard and it covers most of these things and the premium is also quite less. It allows you to have your own lawyer for cases, and they also give you professional help of medical legal help and medical legal assistance. Now, what is not covered in an indemnity insurance? Medical treatment given for weight loss, plastic surgery, genetic damages, and conditions associated with AIDS are not covered under professional indemnity. Criminal acts and penalties and fines arising out of these criminal acts are not covered. Intentional non-compliance or willful neglect or deliberate act is not covered. Loss of goodwill is not covered. Medical practice done under the influence of alcohol or narcotics is not covered. Any liability which occurs as a part of contract will not be covered. And blood banks are not covered. So when I say blood banks are not covered means non-availability of blood. If the case arises because of non-availability of blood, such cases are not covered. Now there is an important concept we should understand in professional indemnity. That is any one accident and any 1 year ratio. So if you have sum assured means the limit of indemnity. That means the insurance cover you have taken, whether you have taken it for 50 lakhs or whether you have taken it for 1 crore. So that is the total sum assured. Now this limit is fixed per accident and per policy period. So this is this. What I mean to say by this is, now if you have a policy of 1 crore and if you take a cover of, say, if you take a ratio of 1:2, that means your sum assured will get divided into 2 parts, that is 50 lakhs, 50 lakhs. And if there is a case filed against you, the only 50 lakhs will be available for that case. And if the compensation awarded goes beyond 50 lakhs, the company will pay only 50 lakhs and the rest of the amount you will have to pay. But suppose you have a 1:1 ratio. That means for any case filed during that year, the whole 1 crore is available to you. So, and it is very difficult that you will have 2 cases in a single year. So if a case is filed against you and say a compensation is awarded of 40 lakhs, then 40 lakhs the insurance company will pay, and still the rest of the 60 lakhs will be available to you if any other cases filed during that year. So it is always preferable to have this 1:1 ratio. Now it is also important to understand what is retroactive date. Now retroactive date means your policy starts from the first day when you first buy the policy. Means the first year when you start practice, you take an insurance, that the day from which you started insurance is your date. So every year when you're renewing this policy, this date or the first date is always there. That means you are covered right from that first date. Now, if you change your insurance company and asked to cover from, you will always ask them to cover from your previous retroactive date. So a small premium is added and you will be covered right from that first day when you started insurance. Because if you change your insurance policy, the previous insurance company will say you're not a client with us anymore. So we will not pay for your case if a case arises after you have changed the insurance company. So what is important is policy should be in force when the incident occurred and when claim arises. Now, many a times some complication might have occurred in the year, say 2012, but a case comes up in 2014 or 2015, or a case is filed later on. So it is important that the policy was in force at the time when this incident occurred and when this claim is made or claim is filed in the court. So you should know what your policy is, whether it is event-based or claim-based. Now, what I mean by event-based is when the event occurred, when the complication occurred. So that is event-based. If your policy is event-based, so you suppose the event has occurred in 2010, and you are no longer renewing this policy, but you had this policy in 2010, then that policy will cover that incidence of 2010. Or whether your policy is claim-based. That means even if the incidence has occurred in 2010 and a claim is filed in 2015, if you are not an insurance holder in 2015, the policy will not cover your complication which had occurred in 2010, even though you had that policy at that point of time. The claim-based policy is when the claim arises, it will cover you at that point of time. So ideally, this is a very gray area. None of the companies will commit whether it is an event-based policy or a claim-based policy. And most of them are not event-based, they are claim-based. So you need to have a cover even when the event occurred and when the claim is raised. So an important question arises, and there was a huge debate. So do we need to continue even after we retire? Or even after our death, should we pay our premiums? So suppose a case arises after our death, do our legal heirs will have to pay for the claim? Now there is a provision in the CPC where it does not allow a case to be filed against dead person. So we might be safe after we are dead. But if you are living and even if you have stopped practice, a claim may arise even after you have stopped practice, and you might have to still pay the liability. So there is some concept called as runoff cover. So that what does this mean is when you retire, you can pay an additional small premium or one premium, which will cover you for the next 5 years or next 10 years, depending upon the negotiations or depending upon the premium you are paying. So even if you have stopped your policy and stopped your practice, if you have paid this premium, it will cover you for the next 5-10 years even after you have stopped the practice. Now, what should you look for in the policy? You should compare the premiums of sum assured between different companies. You should look at what things it will cover, whether it will cover for your unqualified staff, whether it allows you to choose your own lawyer, whether it will allow you to settle your case out of the court. You should look at the track record of the company. What is their claim ratios, or how much have they settled claims? What is the compulsory excess? Now I'll explain this term. What is compulsory excess? Compulsory excess is a percentage of the liability or the liability you have to pay. So some companies will have a compulsory excess of 0.25%. That means if a claim of 1 lakh is filed against you and you have to pay that 1 lakh, 0.25% of that amount you will have to shell from your side, and rest of the amount the company will pay. Now some companies will have a compulsory excess of 1%. Some might have 5%. So also look at this compulsory excess when you're looking at this policy, and whether this policy is flexible. That means whether it will allow you to change your premiums and increase or decrease your coverage as the time passes. So whether this policy is flexible. Now, what should you do? Whether you should buy an individual policy or a group policy? It is always better to take a group policy of association, because there are advantages of this. There is bargaining power. The terms have been negotiated. And if company defaults on the claim, it can be fought collectively. because if the whole association goes against it, it will lose a huge premium. So the companies will not default easily if it is a group policy. Now, how do you claim? Now, as soon as you anticipate medico-legal problem, intimate the insurance company in writing and take acknowledgement. Once you receive a legal notice, inform the insurance company and take a case number. Complete the claim form and forward the legal notice, court correspondence, and estimate of legal fees to this insurance companies. Now, if you get a legal notice and a case is filed, and if you claim later on, the company might not entertain this claim. So it is better, as soon as you receive a legal notice, please inform your insurance company and take a case number, take an acknowledgement. Thank you. That is all about professional indemnity.
So Dr. Nandini, you can give the closing remarks.
I hope my slides were visible and I was audible, because the internet
No,
was
sir, slides were not
visible. You were audible.
okay. Okay.
Thank you very much, sir. Dr. Vani, sir. It was really a wonderful information you shared with us. I'm sure it is going to help everyone who has attended this session. And once again, very much thank you, sir. And thank you, Supriya madam and Patna team, for giving me this opportunity and giving me this privilege to honor chair the session. And just thank you very much. Thank you, ma'am.
Thank you. Thank you very much. Now moving over, I thank the speaker, Dr. Rahul Vani sir, and the chairpersons for chairing the session so well, and the speaker. Thank you very much for coming. So, thank you, sir. So we come to the last session, Dr. Fasiha. So we come to this session 4, where we have got PPH surgical treatment. The speaker is none other than Dr. Fasiha, who is the formal clinical secretary, NOGS. Then to chair the session, we have actually, due to overshoot of time, I think the chairpersons, Dr. Nuradha Garar, secretary, Osmanabad OBGY Society, Dr. Anil Gaikwad, secretary, Miraj OBGY Society, and Dr. Abhay Balsare, that is president, Yavatmal. So moving forward, just show me the CV of Dr. Nuradha. I think she is left. Dr. Anil sir also, I don't think he is here because its time has gone really high. And sir is also, he is currently working as consultant director at Balsare Maternity Hospital, president, Yavatmal OBGY Society. So show me the slide of Dr. Fasiha. Madam is Professor, Department of OBGY, Dr. SC, GMC, Nanded, MD Obstetrician and Gynecology in MD in Obs and Gyne, ICOG Fellowship in Reproductive Medicine. She is consultant in high risk obstetrics since 15 years, an expert in NDVH with urogynecological surgeries, presented many papers and having many publications in international journals. So, ma'am, over to you, Dr. Fasiha. Kindly go for your presentation.
Thank you, madam. Thank you, ma'am. My topic is surgical management of postpartum hemorrhage.
You are not audible.
My topic is surgical management of postpartum hemorrhage. So as we all know that obstetric hemorrhage is a major killer of women of all categories, class and religion, and social and economic status, especially women of third world countries, because of poor resources and infrastructure and in major substandard care are the sufferers. So the obstetric hemorrhage emerges as the major cause of severe maternal morbidity, and in almost all the near-miss cases audits in both developed and developing countries.
Can you make it full screen?
Yeah. So as we all know that all the pregnancies are at risk of PPH, even if no predisposing factor are present.
Yes, ma'am. Now it's full screen.
So we all know the various causes, that is 4T, that is tissue, thrombin, tone, and trauma and coagulopathy are the main reasons for the postpartum hemorrhage. So main is the tone, that is over-distended uterus, uterine muscle exhaustion, intra-amniotic infection, and functional and anatomical distortion are the various causes. Another entity of postpartum hemorrhage is trauma, that is trauma to cervix, vagina, and perineal laceration, extension of episiotomy, then cesarean section laceration, uterine rupture, uterine inversion, and vulval hematoma are the causes. Whenever there is traumatic PPH because of cervical laceration, immediate repair should be done under anesthesia. We can use the ring forceps for holding the anterior and posterior lips of cervix, and we should do the immediate repair of the cervical laceration. Similarly, episiotomy extension should be repaired. If there is intractable hemorrhage, transvaginal ligation of uterine artery by transvaginal uterine artery clamp can be done. Another entity of traumatic postpartum hemorrhage is vulval hematoma, which should be properly incised and drained under anesthesia. All the clot should be evacuated. Then apparent bleeding point should be ligated and primary closure should be done. Exact origin of bleeding is rarely identified in cases of vulval hematoma. The space should be closed with deep mattress sutures. The overlying skin should be approximated without any tension, and the vagina should be tightly packed for a period of 24 hours. Another cause is tissue, that is placental causes, placental abruption, morbidly adherent placenta, placenta previa. Then the next cause is thrombin, that is coagulopathy for PPH. We all know the signs and symptoms of PPH. I will not go into the details of it. Then we all are following the FIGO recommendations for prevention and treatment of PPH. In spite of all these measures, when PPH occurs, one should first go for conservative management of PPH. But if that also fails, one should keep in mind the importance of the golden hour, and timely intervention should be done, which should be able to save the patient's life. So these are various conservative measures which are done in an order to stop the PPH. But when all these measures fails, one should go for stepwise devascularization of the uterus. The steps of stepwise devascularization are uterine artery ligation, utero-ovarian artery ligation, internal iliac artery ligation. For doing all these things, first I must tell you what is the exact vascular supply of the uterus. The vascular supply of the uterus is derived principally from uterine artery and ovarian artery. Uterine artery is the main branch of internal iliac artery that enters the base of the broad ligament and makes its way medially to the side of uterus. The uterine artery divides immediately adjacent to the supravaginal portion of cervix, and it gives away one small cervicovaginal artery that supplies to the lower cervix and upper part of vagina, and the main branch which turns upwards, and it extends, as you can see in the diagram. It extends as highly convoluted vessel that traverses along the margin of the uterus. And a branch enters the upper portion of cervix, and numerous other branches penetrate the body of uterus. Just before the main branch of uterine artery reaches the oviduct, it divides into three branches. One is ovarian, then tubal, and fundal branch. Ovarian branch of uterine artery anastomoses with the terminal branch of the uterine artery. Now, first and foremost step in stepwise devascularization is uterine artery ligation. I recommend that don't go for unilateral unilateral uterine artery ligation. One should always go for bilateral uterine artery ligation. It is of two types, higher uterine artery ligation and lower uterine artery ligation. If the placenta is fundal, one should go for higher uterine artery ligation. Whereas if the placenta is previa, one should go down to dissect the bladder and go to the lower uterine artery ligation. In both a bilateral upper uterine artery ligation and lower uterine artery ligation, one should not only ligate the uterine artery, but one should ligate the entire vascular bundle, which should include uterine artery, uterine vein and the myometrial tissue. The higher uterine artery ligation is done 1 to 2 centimeter just below the level of the uterine incision, and the whole bundle is tied, whereas the lower uterine artery ligation is done 3 to 4 centimeters below the uterine incision. And the same procedure is done, that is including vein, artery, vein and myometrium. And one should be careful while doing the lower uterine artery ligation that one should not injure the bowel. To avoid this, one can keep sponge or left hand on the posterior wall of the uterus to avoid the needle prick injury while ligating the lower uterine artery ligation. Now, coming to the next measure, that is internal iliac artery ligation. We all know there are various indications for internal iliac artery ligation. First is uterine atony, then uterine laceration or rupture, abruptio placenta, placental adhesion disorders like placenta accreta, increta, and percreta. This is the diagram which is showing the anatomy of internal iliac artery, which starts from the common iliac artery. Common iliac artery, at its bifurcation, it gives away two branches. It runs, first is the external iliac artery, which runs straight, whereas the internal iliac artery, it dips down to run. And posterior to internal iliac artery is the internal iliac vein. So I recommend that as there are special indications of internal iliac artery, it should also be done to avoid the hysterectomy, and it is also done to facilitate the hysterectomy and to facilitate the suturing while there is trauma, as it reduces the blood loss, and even while doing the hysterectomy, trauma through ureter and other structure is avoided. Internal iliac artery ligation can also be prophylactically done in cases of placenta accreta, in cases of secondary and reactionary hemorrhage when the bleeder is not seen. Yes. So one should know what is the anatomy of internal iliac artery. So common iliac artery, it bifurcates at pelvic brim and it continues as a straight line as external iliac artery, whereas internal iliac artery dips down, and posterior to it is the internal iliac vein. In cesarean section, in cases of placenta previa and in cases of atonic postpartum hemorrhage, I recommend it is better to close the uterine incision first, as it will stop the bleeding from the venous sinuses as well. Then one should go to the pelvic brim and identify the ureter. Always one should start from the right side first, as on the left side it is a little bit difficult to do the internal iliac artery ligation, as there is sigmoid mesocolon is there on the left side. Now let's go to the steps of internal iliac artery ligation. One should pick up the peritoneum along with the help of a long forceps and cut the peritoneum. Once we cut the peritoneum, the ureter falls back and a nice space in the retroperitoneal region is prepared. One should extend this incision both above and below to 5 to 6 centimeters. It should be adequate enough to retract the ureter medially, and ureter can be easily identified as it is a soft pulsatile structure. And now one should carry out the dissection with the help of fingers to dissect the fascia which is covering the internal iliac artery. Now we all know that the ureter crosses the external iliac artery on the right side, and on the left side it crosses the bifurcation of common iliac artery. External iliac artery is accidentally ligated. Many people say, I just don't believe how external iliac artery can be accidentally ligated while ligating the internal iliac artery, because external iliac artery is going as a straight line, whereas the internal iliac artery dips down. So we should never ever tie the external iliac artery. Now coming back to the dissection of the fascia, it is done with the help of a long artery forceps, and it is done parallel to the vessel on both the sides. And we should be doing all this dissection at least 4 centimeters distal to the bifurcation, as within 1 to 1.5 centimeter, there is posterior division of internal iliac artery, which we don't want to injure. And we are more interested in the anterior division of the internal iliac artery. So now we have to go to the dissection for anterior division of internal iliac artery, that is 3 to 4 centimeters from the bifurcation. If the dissection is not complete, then one will feel the resistance at the mixture. So when the dissection of the fascia, which is covering the internal iliac artery, is complete, then there will be no resistance felt and the mixture can be passed easily. Now the direction of the mixture should always be from lateral to medial side, and never should be medial to lateral side. And one should never force the mixture, and one should not go posterior to the internal iliac artery, as posteriorly there is vein. So mixture must pass closely hugging to the internal iliac artery, 3 to 4 centimeters from the bifurcation. We can take the help of another finger, another hand's finger, to give the counter pressure while passing the mixture, and the mixture is passed closely lateral to medial, hugging to the posterior wall of the internal iliac artery, and of course the anterior division of the internal iliac artery. Now the ligature is passed. I recommend the single tie of the ligature, as double tie should not be done, as it can lead to aneurysms. Now there are certain clinical tips. that monopolar and bipolar electrocoagulation can be used during the dissection of surgical fields. Bleeding from small vessels can stop spontaneously. And before ligation of internal iliac artery, dissection of ureter is extremely important, and inspection is better than just palpation. Now, this is another figure which is again showing the dissection. So similar procedure, as we have done it on the right side, similar procedure should be repeated on the left side. Bilateral ligation of internal iliac artery reduces the pelvic arterial blood flow by 49% and pulse pressure by 85%. After bilateral ligation of internal iliac artery in a long-term period, the collateral circulation will maintain the functioning of the internal iliac artery. Now, these are the various operative complications of the internal iliac artery ligation, that is injury to external iliac vein, internal iliac vein, injury to internal iliac artery, ligation or laceration of the external iliac artery, ligation or laceration of the ureter. Now, a word about uterine compression suture. It is said that it should be the second in the step of stepwise devascularization after ligation of bilateral uterine arteries. One should go for Billings sutures, Christopher Billings sutures, which is because in most of the institutes, the resident doctors are not trained for doing internal iliac artery ligation. I recommend that it should be internal iliac artery ligation should be included in the curriculum of the PG students, so that they will become expert in the procedure and will be able to save the mothers of life. Now, a word about Billings suture. As we all know that Christopher Billings suture is a bilateral compression suture in which the incision is taken at 2 points, point A and point B, and number 2 catgut is used as a suture material which will be passed from anterior wall, and it goes along the fundus of the uterus, and it goes to the posterior wall, and again, and then posterior wall is pierced, and this is actually taken at 3 centimeter above and below the uterine incision, and ultimately it is anchored just below the uterine incision after bringing it back to the anterior wall. Now, there are various problems or various errors while doing the Christopher Billings stitch. Many people, as we all know that these are the compression sutures, it acts as a uterine tamponade, but there are certain mistakes. Many people are not doing it or they are doing it without demonstrating the bimanual compression test. Then if people are doing this procedure, they are following a vaginal delivery, then people are not opening the lower segment hysterotomy, but it should be done and the lower uterine segment should be open to rule out the retained products of conception. Similarly, there is another error, that is error in suture selection. As in original Christopher Billings suture procedure, the suture material which was recommended was catgut number 2, whereas catgut may not last long. Reports have been there that polyglycolic suture material have also been used and it lasts long. Similarly, another error is that expecting the Billings suture to restore the uterine tone. In many cases have been reported where we have seen the reports that uterus continued to bleed even after the Billings compression sutures. So next method of compression suture is Heyman suture, where the knot is tied on both the sides over the fundus of the uterus. Then Chow multiple square sutures. Here the multiple square sutures are occluding the uterine cavity are taken. A word about uterine artery embolization. In the institutes where this facility is available, it is a safe, minimally invasive procedure reported with a success rate of more than 90% in treatment of postpartum hemorrhage. Now, a word about obstetric hysterectomy. There are 2 types of obstetric hysterectomy, total and subtotal hysterectomy. There are various indications like abnormal placentation, that is morbidly adherent placenta, uterine atony, uterine rupture, extension of uterine incision, and uterine infection. Now, the points to consider while doing obstetric hysterectomy are that normal pelvic anatomy may be distorted, vascular pedicles are thicker and edematous than in non-pregnant state. Vascular pedicles should be doubly clamped to avoid slippage of ligature. Small pedicles should be secured and knots tied when they are in correct anatomical plane without torsion or twisting of the pedicle. Bladder might be adherent to lower segment, especially in previous cesarean section. Then presence of uterine tear or extensions of uterine angle might include the risk of ureteric injury. Then unintended oophorectomy due to shortening of ovarian pedicles. There may be difficulty in identifying the cervix, especially if the hysterectomy follows a cesarean section done at a full dilatation of cervix. Then tissues might be friable, and this can pose to added difficulties. Now the procedure, as we all know, first step is transection of round ligaments, then transection of tubo-ovarian ligaments, then transection of uterines on both the sides, then clamping of cardinals. If the cervix is fully dilated, one should palpate the upper vagina and pinching to palpate the cervix, hooking the finger between the cervical rim and the vaginal wall through the cesarean section. This is the figure showing the same. Now a word about vault repair. Each of the lateral vaginal fornix is secured to the cardinal and uterosacral ligaments. Achieve hemostasis by running lock stitch of vicryl placed through the mucosa and endopelvic fascia. Many people prefer to close the vagina using figure of 8 chromic catgut. Indwelling bladder drain and suction drain should be kept. Next. Now a word about total and subtotal hysterectomy. Total hysterectomy is a surgery of choice in cases of central placenta previa, whereas subtotal hysterectomy is done if the patient is unstable, when the removal of cervix is not essential for hemostasis, and when the bleeding is due to uterine atony. This is the figure which is showing subtotal hysterectomy. Regarding post-operative care, record the indication for surgery, have a discussion with the patient when she recovers, especially in primary patients, tackle the postnatal symptoms that require counseling, keep the bladder draining for 7 to 10 days in cases of bladder injury. A word about complications of hysterectomy: febrile morbidity, blood transfusion, coagulopathy, urological injury, reoperation in cases of intra-abdominal hemorrhage and other organ damage, and ICU requirement. A word about incidental bladder injury during obstetric hysterectomy. Gush of clear fluid in the operating field will be evident to show that there is bladder injury. Then repair at the primary surgery is preferred. It lowers the risk of VBF. After confirmation of ureteral patency, bladder closure should be done by 2 to 3 layered running closure, and continuous bladder drainage is done in postoperative period. A word about oophorectomy. Due to inadvertent clamping of the ovarian ligament at times to stop bleeding from infundibulous pelvic vessels, and 5% of peripartum hysterectomies, one adnexa was removed to stop bleeding. A word about morbidly adherent placenta, which can lead to intractable hemorrhage. As we all know, placenta accreta, increta, and percreta. We would like to report a case of successful surgical management of placenta accreta in a 28 years old, 4th gravida with previous 3 cesarean sections, presented 34 weeks of gestation. Her ultrasound was showing left lateral low-lying placenta and distal and reaching internal os, covering it on the left side with increased vascularity, noted at urinary bladder interface with lacunae seen in placenta, suggestive of placenta accreta. She was planned for elective C-section at 35 weeks, and relatives were informed about the high risk of massive hemorrhage, need of blood and blood products, and need of cesarean hysterectomy. Under general anesthesia, laparotomy was done with midline vertical incision 2/3 above and 1/3 below the umbilicus. Uterine incision was taken over the fundus, extending over both anteriorly and posteriorly. Baby was delivered by a breech, cord clamped and tied with sutures. This is the figure which is showing uterine incision taken over the fundus, extending over both anteriorly and posteriorly. A full-term male child was delivered by this procedure. Evidence of large placenta on left lateral side in the whole lower uterine segment. Uterine incision was quickly closed in a single layer. Then we proceeded quickly for bilateral internal iliac artery ligation. Then cesarean hysterectomy was done with careful sharp dissection of bladder without any injury. Entire lower segment invaded with placenta could be gently separated from bladder. Total hysterectomy was done. Hemostasis was achieved. Bladder integrity was checked with methylene blue. Laparotomy incision was closed in single layer. So the take-home message in this case is that one should take help of urologist in cases of placenta percreta involving posterior bladder wall. In some cases, partial cystectomy may be required. In our case, we were very lucky; we did not require all these things. Then help of interventional radiology can be also taken in cases of suspected placenta accreta, preoperative placement of internal iliac artery balloon bilaterally to decrease the blood loss, avoiding the need of embolization. This is the specimen showing placenta accreta invading the entire lower segment in our case. Now, a word about uterine inversion, which is also a major cause for postpartum hemorrhage. Nowadays, very less cases are seen of uterine inversion. When I was a PG student, we used to, my institute being at periphery, we used to encounter many cases of uterine inversion, which we used to manage by laparotomy. Nowadays, we are managing it by laparoscopy. This is a figure which is showing the laparoscopic appearance of the inverted uterus. Here it is managed laparoscopically, where a 5 mm forceps being used to press down on the top of the inverted uterus, then partial reduction is achieved, then further reduction was completed using a 10 mm blunt tipped Teflon rod to press down on the top of the inverted uterus, and then complete reduction is achieved. In figure D, you can see the completely reduction done in case of inversion of uterus. Thank you all for the patient hearing.
Thank you, Dr. Fasiha, for your very elaborate and very, you have covered everything in your talk, in your brilliant presentation. Actually, you have touched right from the beginning to the end. So we need not, you have done the whole chapter. So, and the videos the pictures were good and very clearly the sections were shown. So thank you very much for your wonderful presentation. I appreciate you for this, and thank you for accepting the invitation and coming to us. Thank you very much. You are muted, I think. Your voice I can't hear. Yeah.
Thank you, ma'am. Thank you so much.
Ajay Mane, sir?
Yes, ma'am.
So now we have come to end of this whole program, sir. So thank you very much.
Yes, great. I have heard all the lectures. It was very nice. Yeah. Unfortunately, we cannot see we could not see the slides of Rahul Wani, sir.
Yes, that was.
But his explanation was very nice, and he's the master in that field. So anybody who is in need of the advice, they can contact Dr. Rahul Wani, sir.
Yes.
And thank you, Supriya Madam, for inviting me here.
Yes.
And it was a nice webinar. Thank you very much.
Thank you.
And
Dr.
best luck for your re-election.
Thank you, sir. Thank you. Hardly any time left now. So Dr. Anjali, thank you, and thank you for staying on till the end. Thank you so much.